So why don't we go ahead and get going? Good morning, everyone. I know it's early, but we appreciate you getting up, especially for the lineup of speakers that we have here today. Welcome to the third annual MCW UW-Madison Brain Metastases Symposium. My name is Joe Bovee. I'm a professor of radiation oncology at the Medical College of Wisconsin in Milwaukee, and it's my pleasure to co-host this event with Dr. Mahua Day from UW-Madison. We're very excited to have everyone here today, very excited to listen to the excellent speakers that we have lined up. This has turned out to be just an absolutely amazing event for us to put together. We started this actually right before the pandemic had hit. And so we had moved to a virtual format, which we've enjoyed. What's amazing about this is that last night was the first time that Dr. Day and I had a chance to meet in person for a true kind of speaker dinner, but without the speakers still. So that was actually a lot of fun. So welcome, and we'll get started in just a bit. Dr. Day, anything to add?
No, it is great pleasure inviting everybody to this symposium. I'm Mahua Day. I'm a neurosurgeon at UW-Madison, and it's been a pleasure co-hosting this with Dr. Bovee. And we hope one day, soon in near future, we can have people here in person and do this more where we can see people face to face, just like we did last night. But in the meantime, we're really fortunate to have like the world experts speaking on these symposium on brain metastases. So.
All right, wonderful. So why don't we get going here? I'd like to take just a minute to introduce Dr. Sarkaria, who's a professor of radiation oncology at Mayo Clinic in Rochester. He had attended medical school at UCLA. He actually has ties to the Wisconsin area as he did his residency in radiation oncology actually at UW-Madison as well. His laboratory work is currently focusing on drug penetration across the blood-brain barrier for intracranial disease. And today he's going to share with us some of his knowledge on radiosensitizers in the treatment of brain metastases. So Dr. Sarkaria, thank you so much for joining us today.
Great. Yeah. Thanks so much for inviting me. I really appreciate the opportunity to talk about stuff we've done. And as you mentioned, I've ties back to Madison. We were actually in Madison last weekend for the football game and a volleyball game. So go back.
Well, you're wearing your Madison red, sir.
I am. I got my little, UW.
I see Badger there on Wisconsin.
Exactly. You got it. Great. So let's see if I can. Here we go. So learning objectives, learn about radiosensitizers in brain metastasis and think about normal tissues. We have lots of contract work with companies, but I'm not going to be talking about any of that work. So in general, radiation therapy, so brain metastasis, there's three main treatments that we think about. There's surgery, radiation, and chemotherapy, immunotherapy. And for many patients, radiation becomes the standard of care, and there's really two modalities that we use for radiation. One would be whole brain radiation therapy, oftentimes with hippocampal avoidance, as shown here on the left, and then other times radiosurgery, where we can deliver very focal radiation just to individual metastasis. And either strategy triggers a lot of DNA damage that needs to be processed and repaired. And if it's not successfully repaired, that's what leads to cell death of both tumor and normal tissues. And so, a pretty important pathway is the MRN ATM pathway that triggers H2EX histone modifications. And ultimately, the sensing of the damage here is repaired either by non-homologous end joining or homologous recombination. And FIT3BP1 is one of those deciding factors as to which way an individual DNA lesion will be repaired. And the reason this is important to review is that there are now very potent inhibitors that can hit non-homologous end joining, homologous recombination, ATM. So there's a lot of interesting drugs that now can be used as potent radiosensitizers. And we're going to talk about one of those, which is going to target non-homologous end joining. So DNA-PKCS actually forms a trimer. This cartoon is a little bit inaccurate in that DNA-PKCS binds with Ku70 and Ku80 to broken DNA ends and facilitates the religation of these broken DNA ends. And if successful, then those cells can survive, whether it's tumor or normal cells. And there are now really potent inhibitors like pepasertib, which inhibits the kinase activity of DNAPK CS, and that can prevent DNA repair and then lead to tumor cell death. And so we've been quite interested in understanding how pepasertib could be used both in glioblastoma and brain metastasis, and our work kind of took us down a brain metastasis pathway. But there are 14 clinical trials ongoing with pepasertib in GBM, advanced head and neck, pancreas, and rectal cancer. And some of the stuff I'll talk about actually applies to all these trials. So just to kind of go over, again, DNAPK-CS and what pepasertib as a DNAPK inhibitor does. So in the face of radiation damage, you trigger a lot of DNA damage signaling, and some of that's mediated by DNAPK. And so with no radiation, one of the mediators of actually ATM signaling, with that molecule that sits upstream of non-small cell joining, is CAP1, which is, I think, a good measure of just general DNA damage activation. And as we increase the dose of pepasertib without radiation, we don't see any effect. But as we increase the dose of pepasertib in combination with 5 gray of radiation, we actually see greater and greater damage signaling, seen here in the CAP1 Western blot. And conversely, DNAPK can autophosphorylate or put phosphorylation molecules on itself as a way of regulating its activity. And that's really triggered by radiation. Here with no pepasertib, we see robust DNAPK alteration. And as we increase the dose of pepasertib, also known as M3814, that's the initial name, the code name that the company gave it, we see suppression of DNAPK phosphorylation, which basically just indicates the drug is working. The drug is inhibiting DNAPK activity, and it's actually increasing damage signaling or impairing DNA repair, I think is the way I think about this. And we see this both in a melanoma PDX line, M15, and a second melanoma brain met. These are both brain metastasis PDXs, and M12 is another one that we have. And you can see with radiation only, again, CAP1, which is a measure of just unrepaired DNA damage, I think is probably a good way to think about it. Early on, it's robustly activated, and by 4 and 6 hours, you're seeing it really fade away. Whereas when we combine the M3814 or pepasertib with radiation, we see the sustained delayed repair of DNA damage. Also, when we combine M3814 or pepasertib with radiation, we see increased cell killing. This is a standard clonogenic assay. So we put the drug on, 30 minutes later, we give the cells radiation. Here's an example of those cell plates. And we give them escalating doses of radiation with or without the pepasertib. And when we measure the survival 14 days later, the number of colonies that show up on the plate, you can see with pepasertib combined with radiation, it's much more effective at decreasing number of colonies on the plate than with radiation only. And that's reflected here in the survival curve. So at 300 nanomolar pepasertib, we see robust radiosensitizing effects, almost doubling in cell kill at 2.5 gray, which is pretty close to what we do for standard whole brain radiation therapy. Usually we do 3 gray. And then again, just another measure of delayed DNA repair. We're looking at gamma H2AX foci. Again, this is kind of just a measure of unrepaired damage that sits upstream and it should be repaired by non-small cell joining or DNAPK. And so with radiation only, we see these foci form. This is by immunofluorescence. And by 8 hours, we're seeing that fade away. Early on, we see pretty good foci, but fading away by 8 hours. And here with pepasertib inhibiting DNA PK, inhibiting non-small cell joining, we see sustained H2X foci as a measure of DNA damage. And you can kind of see the quantification of that effect here. Black is radiation only, blue is pepasertib only, and red and black, or sorry, red is pepasertib plus radiation. And you can see just at multiple time points comparing to radiation only, the pepasertib is delaying the recovery or repair of those H2X foci. It's only early on. We don't see greater induction of DNA damage, so the foci here are the same, but we just see delayed resolution of those foci. Here's radiation only. And then finally, the other thing that we wanted to look at was how long do we need pepasertib on board in order to maximize the sensitizing effects? Because when we start thinking about moving from cell culture to animals and ultimately to humans, in cell culture, we put the drug on the cells. It stays at that concentration for as long as we leave the cells, that media on the cells. And oftentimes in the clonogenic, you might leave the drug on for 24, 48 hours before you wash it off, or you might leave it on, without washing it off at all. But in animals, we see, when you dose with drug, the drug levels go up, and then they start coming down. And so it's important to understand how long do you need to hit your target concentration. So here, what we did is we added our 300 nanomolar M3014, and then at different time points, we removed the media and replaced it with fresh media. And so here are cells that were treated with the DMSO control, and here are the cells treated with M3014. And it's normalized to 1, so that it's these cells got 2.5 gray, and we're normalizing 2.5 gray with no drug as 1. So we're kind of looking at the relative enhancement in cell killing. So you can see that if we start removing the drug, if we don't remove the drug, we just have it on continuously, we see significantly greater killing than with radiation and vehicle control. And as we start washing off the drug at earlier and earlier time points, we start losing that sensitizing effect. And so just subjectively, it appears that, you really need that drug on board for about 16 hours to see maximal sensitizing effects. You don't gain a whole lot going past 16 hours. So that gave us a target. 300 nanomolar total concentration in media for 16 hours is what, that's kind of what we want to see in an animal or in a human. And so that kind of gets us now to the pharmacokinetics of the drug. If we just follow this blue line here, we dose the animals, and then we're measuring drug at different time points. And you can see it goes up fairly quickly and peaks around 3 hours, but then starts to fall off fairly quickly. And if we didn't redose the animals here at 7 hours, it would continue to fall and fall and go well below our target concentration. Here I've noted at 150 nanomolar, which is free drug that's not bound in media, but it's basically the same thing. We want to maintain our target concentration above 150 nanomolar free drug or 300 nanomolar total drug for at least 16 hours. So our goal is to keep these curves above this dotted line for about 16 hours. And so we just simulated based on measured PK. At a single concentration. Now we're simulating what the exposure would be at multiple concentrations or multiple doses in the animals. And so if we dose the animals at 30 milligrams twice a day, we just don't ever reach our target concentrations, and we really need to be at 60 or 90 to get to what we think is a good target concentration. And 125 twice a day might be even better. So just looking at that, we have 3 different melanoma brain metastasis patient-derived models, and I'll just talk to you about M12 here first. So based on that simulation of looking at different dose levels, we decided to treat our animals with radiation. Here we're given 2.5 gray times 5 fractions. So it's about a third of what we would give patients if we were going with an aggressive whole brain radiation regimen. So radiation only compared to vehicle. These mice have tumors implanted into their brains, and then we're radiating their brain with opposed laterals. So very similar to what we do in humans. And so there's a nominal survival benefit for the radiated animals versus the unirradiated animals. There's 10 mice in each group, in each treatment group. Mice that are randomized to combined M3814 or pepasertib with radiation. And again, we're giving these doses twice, 7 hours apart. 60 and 90 milligrams per kilogram have some benefit, but it's not as good as if we go out to 125 milligrams per kilogram. So just to flip back to this, we're basically saying, with the green and the red at 60 and 90, we get, especially 60, we're kind of falling out of our target window fairly early. We fall out of our target window here and here. 90, we're kind of just above it, and 125, we think we'd really have good exposure. And that's kind of what we're seeing here. 125 given twice with each fraction of radiation. And again, this should be labeled a little bit differently. It's 2.5 gray times 5 fractions. This is our better sensitizing effect. And so we went forward with subsequent studies, always looking at 125 mg per kg in these different 3 different models. So this is again a repeat of M12, but in a new experiment. Same idea, 2.5 gray times 5 versus placebo. Not a lot of benefit. And then if we do M3814 plus radiation, the same radiation regimen, M3814 at 125 mg per kg, we see significant survival benefit. And then in M27, it's a little bit less impressive as far as the benefit between radiation only and radiation plus drug. And M15 is intermediate as far as benefit between radiation and radiation plus drug. So, it kind of suggests like, hey, we have 3 melanoma brain metastasis models that see variable levels of benefit, with M12 being reasonably impressive, with really no radiation effect here, and you can really enhance that survival. And M27, I would say, is not really interesting. It's not that good. And M15 is intermediate. So there's a reasonable rationale to think, hey, we should pursue. Should we think about a radiosensitizing regimen for melanoma brain metastasis? And one thing that's interesting is we know from other pharmacokinetics studies that the distribution of drug into the normal brain is actually pretty limited for this drug. It's about 10% of the plasma. So we wanted to really look and see in M12 in particular, were we getting decent drug levels into the middle of the tumor, and is that why we're seeing good sensitizing effects? So to do that, we have tumor lines that are transduced with GFP, and so we can use fluorescence imaging to image where the tumor is. And so these mice, this is an M12 tumor with a GFP expression, and the mice are dosed with pepasertib either 2 hours or 6 hours before being euthanized. Then we collect the brain and plasma and measure drug levels in the tumor core, and then in the normal brain on the contralateral portion of the brain, and in plasma. And you can see those results here. If we think about 300 nanomolar as our target concentration, the drug levels in brain are marginally at that radiosensitizing level 2 hours after dosing, but by 6 hours after dosing, they fall well below the target dose level. Again, this is a log scale, but our brain, the tumor still remains above our target. And so this starts to suggest, well, maybe one of the concerns is that, are we going to radiosensitize the normal brain with pepasertib? And so this is starting to say, well, maybe it's not, maybe we're going to spare the normal brain with this drug. And that's really kind of critical, because non-homologous end joining is responsible for the majority of DNA repair after radiation, and especially for any cell that's in G1, which is essentially all CNS tissues are not proliferating very quickly. So we would expect that non-small cell joining, which is the target of pepasertib, would be really important for radiosensitizing all tissues in the brain. And so we're trying to really think about the therapeutic window. Where is that risk of normal tissue injury with radiation dose versus tumor, and how does that shift? If we shift the risk of, or the benefit or the amount of cell death with radiosensitizer for tumor, but we're actually also shifting the normal tissue this way, that would be the wrong direction. And so we either want to keep it the same, or ideally you protect it further. And so, we wanted to look at that a little bit more carefully. So we looked at an astrocyte cell line, SVGA. It's a immortalized astrocyte cell line, and with M3814 or pepasertib, we can see, similar to M12, pretty significant radiosensitizing effects, radiation only. Looking at cell kill versus radiation plus drug, for any given dose of radiation, we see more kill with M3814 plus radiation than radiation only. And then in a human iPSC cell line that's differentiated down a neuronal lineage, and just we can't do clonogenics in these cells, but we can look at H2AX. And H2AX again is that marker of DNA repair. And with radiation at 4 hours after radiation, we see, it's kind of the H2AX foci are starting to resolve, but with pepasertib, similar to our M12 studies, we see sustained gamma H2AX foci, suggesting that a neuronal lineage cell would be sensitized with M314 if would combine with radiation. So yeah, you really need to start thinking about the normal tissue potential for normal tissue injury. One thing I mentioned earlier, that the brain distribution is limited by the blood-brain barrier, and so that's kind of illustrated here in the pharmacokinetics for the drug. And this is these mice are dosed. There's 5 mice per time point, and they're dosed with drug. Then we're harvesting plasma, brain, and spinal cord. And you can see even at peak concentration, about 2 hours, there's about a log-fold difference in drug levels in brain versus plasma. And that's sustained over a long period of time. And so if we start looking at modeling, what if we dosed our mice with 125 mg per kg, that's where we thought we had the best radiosensitizing effects. What's that free drug concentration with that dosing? And remember, our target concentration is 150 to 300 nanomolar. So we're way below that target concentration for radiosensitizing effects. And the drug that's available to bind the target should be much lower than required for radiosensitizing effects. So it's kind of an interesting strategy that this drug could protect the normal brain because it's excluded from the normal brain, so you won't see the radiosensitizing effects in the normal brain, but you would see the radiosensitizing effects in the tumor. So to try and look at that, again, we came to our H2AX foci assay. So again, H2AX measure of just unrepaired DNA damage. And here we took intracranial tumors, M12 intracranial tumors, and we gave them drug with or without radiation, and then 4 hours later we harvested these animals, and then we're staining for gamma H2AX both in the tumor but also in the hippocampus as being a key target for radiation-induced injury. And so just looking at gamma H2AX foci in the tumor versus with no treatment, these are tumor cells, and so they have a fair amount of endogenous DNA damage without any radiation. So we're seeing a distribution of cells with a variety of gamma H2AX. With radiation only, there's really no difference compared to vehicle at that 4-hour time point. So we're kind of radiating at a time point where we expect to start seeing resolution of the gamma H2AX foci in tumor, and that's what we see. But when we compare that to radiation plus pepasertib in the tumor itself, we're seeing sustained or delayed resolution of those gamma-H2AX, again, consistent with this idea that we're sensitizing the tumor because we're impairing DNA repair in the tumor. On the flip side, when we look at the hippocampus with radiation only compared to vehicle, again, the y-axis is quite different, 50 here versus 5. So normal brain should have a much better regulation of DNA damage repair and have much less endogenous damage. With radiation, we see elevated gamma-H2AX foci at 4 hours. That's consistent with this idea that CNS repairs DNA damage from radiation slower than tumor. One of the reasons why we typically don't do twice daily radiation in the brain. But importantly, when we combine radiation with pepasertib, we don't see any evidence of delayed repair. This is significantly different with lower gamma-H2AX in the radiation plus pepasertib. I don't know if I have a good explanation for that or whether that would be reproducible, but at least it's not the opposite. And so again, it's kind of consistent with this idea that the exclusion of pepasertib from the CNS is protecting the brain from the radiosensitizing effects, while we still see radiosensitizing effects in the tumor. And that's just kind of just summarizing some of the stuff that we've worked on. We used our understanding of DNA repair kinetics in brain and tumor to really start trying to define an optimal dosing regimen. We use multiple patient-derived xenograft models to evaluate the efficacy of that model. And we're really focused on understanding the therapeutic window because we want to make sure that we're not causing more problems than we're solving. And I'm going to just close with 2 slides because it was really interesting. You know, we kind of went down this road. We were fairly agnostic about brain tumor, about GBM versus brain metastasis. And because of the exclusion of the drug by the blood-brain barrier, we felt it was better suited for brain metastasis that may have a more open blood-brain barrier. But when we brought this to our clinicians to start thinking about, hey, how could we design a clinical trial around brain metastasis? It was really difficult to think about what that strategy should be. And, you know, I think there's been a really big change in the last 10 years, certainly the last 20 years since I was a resident, well, 25 years ago or so. You know, we use whole brain radiation therapy much more sparingly, and we tend to use whole brain therapy closer to going to hospice. And that's really, the rationale for that is really illustrated by this study by Paul Brown here at Mayo, where they compared stereotactic radiosurgery to whole brain radiation therapy plus stereotactic radiosurgery. You know, we saw better local control with the combination of stereotactic radiosurgery and whole brain, but no difference in overall survival. And patients who got whole brain radiation therapy had some cognitive injury that was more pronounced than, and there's been other studies looking at stereotactic radiosurgery versus whole brain radiation therapy alone. So there's a big move towards using radiosurgery. And, you know, the challenge with radiosurgery is that we're pretty good at it, at least for small brain metastasis, even, you know, radio-resistant tumors like melanoma. We have good local control rates, and for the larger tumors, we generally they might go for a resection and radiosurgery for the surgical cavity. So it was really challenging to try and find a role for developing a radiosensitizer with DNPK inhibitor and radiation. So that's kind of I don't know. I just thought it was interesting. Like, you'd think it'd be, you know, we have some pretty cool data, but it's not clear how we want to develop that. So, anyways, I'll end with that. Just like to thank everybody who did the work. This was really driven by Jinjang G and Sonia Dragovich and Meg Connors, and then our collaborators at University of Minnesota, Bill Umquist and Surabhi Telalay. I'll stop there. Thanks so much.
Thank you so much, Dr. Sakara. That was a great talk, and definitely it's fascinating to see how you take something like preclinical and then slowly think about clinical application of that. And with I mean, we're good at SRS, but there's still local failure. The dosing is not still as homogeneous to the periphery versus center. So do you think that's an avenue for this to evolve? I mean, we're good,
Yeah.
but we're not like, we haven't like cured, we don't kill, we still fail.
Yeah, no, I think there's definitely an avenue. I think the challenge is, what is the clinical trial, like accrual on the clinical trial and the speed of executing the clinical trial, and just the practice. And that's kind of an ongoing discussion I'm gonna have with our, I mean, I treat patients as well, but I'm mostly in the lab, so I'm not the best person to drive a clinical trial. So it's kind of an ongoing discussion with some of our junior faculty as to if someone wants to run a clinical trial like that.
Yeah, I agree with Dr. Day. I think there's an opportunity for perhaps utilizing this, especially in an era of that pendulum having swung from whole brain radiation therapy to stereotactic radiosurgery, especially for like large or unresectable metastases, right? We still struggle with that. While we say large mets are oftentimes resected and then we treat the cavity, there are still some where the morbidity of that resection would be worse than just leaving it alone. So I think I do agree. I think there's probably an opportunity for some of those clinical situations where you'd want to have increased sensitization in order to try to drive those control rates to the same levels of like the 80 to 90% that we see for small mets that we're able to treat to higher doses. You know, it was always confusing to me in my training. You know, we have larger mets, yet we give a lesser dose in order to try to decrease risk of necrosis. But perhaps that lesser dose coupled with a sensitizer, it's a win-win, right? You'd have an opportunity for a higher level of control of that disease process and still a lesser extent of injury to normal tissue. So I do agree. I think there's an opportunity there for sure.
Yeah, I think it's interesting, and that's kind of where we're moving to is there a venue for fractionated SRS with radiosensitizer? I think that's kind of, to me, the interesting question. I think there's actually a role in whole brain as well, because with the protection of normal tissues, and nobody's excited about ridding a melanoma with whole brain, because the control rates are dismal. But it's kind of the patient population it's been challenging to accrue patients to whole brain clinical, radiosensitizer trials in whole brain for us.
For sure. Well, I can't thank you enough. That was just a wonderful talk. Thanks again.
All right, thanks so much for inviting me.
Absolutely.
Absolutely.
Now we're going to move to our next speaker. I'm very excited to present our next speaker, Dr. Amit Ray. Dr. Ray is a consultant neurosurgeon at Apollo Hospital in India. His clinical practice and expertise lies in surgical neuro-oncology. He's an international leader in liquid biopsies for the diagnosis, molecular profiling, treatment of brain tumors. And it's really exciting that he's traveling to Snow, and he's joining us, I think, from airport. Am I right, Dr. Ray?
Well, no, I'm at my cousin's house in Pittsburgh, so it's a bit better than an airport.
Well, we are very thankful that you could still squeeze us in between your travel and jet lag. So we really appreciate that.
Yeah. At the very outset, I should say, please excuse my nephews screaming in the background if you hear them, but I hope they'll be quiet. And thank you very much for inviting me. It's an absolute pleasure to be speaking at this platform. I must say, my all my work in liquid biopsies is centered around gliomas more than anything else. So what's going on, and I think brain mets could be one of the things where liquid biopsy comes in first. To sort of augment what we do clinically. So I think it's a very exciting time, and I'm very excited to present some of the work that's going on around the globe.
Wonderful. Thank you.
Okay, so thank you once again for the invite, and I call my my talk "Back to the Future," and I say it's back to the future. For before that, I don't really have any kind of Can you see the screen all right? Is the screen okay?
Yes,
We can see it.
Yeah, okay, right. So Exogen Research is a company that I sort of founded, and it doesn't have any products approved by the FDA. It is basically a liquid biopsy company, and we're trying to find out if we can find out, if we can get to a point where we can have a diagnostic for gliomas, basically, right? Now, I know there are lots of sort of neurosurgeons in this meeting, and I just wonder if anybody remembers doing a lumbar punctures for medulloblastoma on a postoperative day. And as it would have it, it was one of the first tasks that I did as a PGY1 when I joined neurosurgery. I remember it was about a 12 or 13-year-old girl, and I remember it extremely well. And I was asked to go to the ward and do a lumbar puncture to see if she had metastatic disease, right? And here I am about, I think, 20 or 25 years later, presenting, CSF sampling and liquid biopsies for metastatic disease, right? So I think we are sort of back to the future. We are back 25 years, or maybe forward 25 years. So at the very outset, what is liquid biopsy? It is a sort of a very minimally invasive approach where we can assess a tumor by not actually biopsying the tumor, but by examining the biofluids that surround it. It's usually blood. In CNS tumors, it's metastatic disease, or in metastatic disease, it could be CSF. In oral cancer, which is very, very, very common in India, it's saliva, and in urogenital cancers, it could be urine. So it could really be anything, in any kind of fluid that comes out of the body. We could actually look at it and get a diagnosis, right? And there are multiple things that we could look at. We could look at circulating tumor cells. We could look at cell-free DNA. We could look at exosomes. We could even look at platelets, and there's something called tumor-educated platelets and serum RNAs and proteins. But I am, in this talk, I'll concentrate on circulating tumor cells and cell-free DNA, which is sort of known as ctDNA in short, because that's the most studied. And recent guidelines sort of allude to those more than anything else, right? At the very end, I'll talk about exosomes, in which my current interest lies. And there's some very, very interesting things around exosomes that I think need some more research. And it'd be great to collaborate with people who are interested in metastatic disease to see where we can go, right? So ctDNA is something that is cleared by the blood and the kidneys, variable half-life in circulation. And we really don't know exactly how long it lasts. Some say it lasts 15 minutes, some say it lasts several hours, but I think we now sort of think it's more hours than minutes, right? And the proportion of tumor-derived ctDNA is broadly related to the size of the tumor and the extent of the disease. Now, when I say extent of the disease, if there is metastatic disease, and I will allude to this in my talk later on, I think the profile that you get in the blood is different from if you have just one primary. And if we do serial biopsies, I think we will see how the profile changes from time to time, right? The other thing about liquid biopsies is that the tumor is very, very small when you can see it in blood. It's about 1.5 millimeters, which is about 44 million cells. And that is beyond the scope of any kind of MRI or CT imaging. So here lies the challenge, right? If we find something in the blood and we still don't see it in any kind of imaging, what do we do? I think that is a challenge that we will cross, and I think we need some longitudinal studies to prove that what we see in blood is actually true. And I'm actually not going to go there. I'm going to go to where we have demonstrated tumor in some kind of radiological form. Okay. ctDNAs can be detected in almost all tumors, all solid tumors, not only with advanced disease, but also with disease that is just starting. Other than a very sort of small minority of tumors, I think it is universally accepted that ctDNA is probably the way to go. The proportion of tumor cells that release ctDNA, we do not know. exactly what proportion actually releases ctDNA, but it is thought that it comes out of dying cells. Though recent research has suggested that it's not only the dying cells that produce ctDNA, but also it's actively secreted into the bloodstream by tumor cells, right? And these mutations mimic the tumor. So what we see in the blood broadly mimics the tumor. And it's not only the tumors that they mimic, but even their methylation profiles. And I think there's been a very nice paper out of Gelarizade's group in Toronto, where they've shown it not in metastatic brain disease, but they've shown it in in meningiomas and other tumors, that the methylation patterns in the blood actually made the diagnosis of meningioma possible. So what is sort of new and what is peculiar about brain tumors and about brain mets? Well, we all know about this, right? We know about the blood-brain barrier. We know about tight junctions between endothelial cells and astrocytes. But there are certain other things, such as efflux pumps like proteoglycan and the breast cancer-resistant protein, which actually actively prevent anything from growing into the bloodstream, right? And the blood-brain barrier is actually normal for mets less than 1 millimeter. The blood-tumor barrier is leakier than the blood-brain barrier, and they do not have the tight junctions that are seen in the blood-tumor barrier, but in the blood-brain barrier, sorry. But the permeability is still very much dependent on the tumor. And of course, we have metastatic disease that is confined to the subarachnoid space, or it is within the CSF, and therefore it is confined by the subarachnoid space. Now, we have thought for a very long time that the brain was immunologically a separate entity altogether, that it was privileged, etc., etc. But I think now that kind of dogmatic teaching is changing. And we have seen that, parenchymal and leptomeningeal lymphatics drain into cervical lymph nodes, and we've seen metastatic disease in cervical lymph nodes from what seems to be only disease that is confined to the brain. So a lot of things are changing, but these are the three major things that sort of make brain mets different from mets anywhere else. So what can we look at if we look at brain? If we try to look at liquid biopsy, we can look at CSF or we can look at blood, and these are probably the two most important and two most investigated forms. So CSF, not many cells, low background DNA, low background protein and lipid content, and actually a higher concentration of both ctDNA, exosomes, and circulating tumor cells. However, if we have large tumors, we cannot do lumbar punctures. It often requires a specialist to actually tap CSF. And therefore, its widespread use in the community may be restricted. Blood, much, much easier. A venous sample can be taken anywhere, even at home. It is suitable for all tumor sizes. It actually doesn't matter how big your tumor is, but in a very sad way, the bigger the tumor, the more the chances are that you will see it in the blood. But processing is difficult, and we always run into problems with, blood-brain barriers and blood-tumor barriers. And for that matter, we do not really know how much exosome we will see if the spread is only in the subarachnoid space, right? So these are things that we still don't know, but it looks like CSF and blood will be the way to go where we're talking about brain mets. Now, why do we think brain mets and liquid biopsies are sort of a match made in heaven, right? Parenchymal brain mets are temporally and spatially distinct and demonstrate clonal evolution. So if there is something that is growing and mutating, and as the tumor spreads, there is evolution of the mutating patterns, then surely one biopsy in one time point is not the answer. And we cannot go biopsying every, met everywhere in the body. So there has to be a way where we can summate all the possible targetable mutations that happen in a tumor that has spread everywhere in the body, including the brain, without biopsying every tumor that there is. And I think here is where blood is such an important entity for liquid biopsies, because this is where we can actually sample and demonstrate clonal evolution. And I think that has been done already in a fair number of samples, not particularly in brain, in tumors of metastatic tumors of the CNS, but in general, we have seen that clonal evolution has been shown through ctDNAs in the blood in several cancers. We have been doing cytology or CTCs or circulating tumor cells for a very long time. And as I said, almost 25 years ago, I was doing lumbar punctures to take out cells that were seen by the pathologist, and that was cytology. Now we have CTCs, which is slightly different from cytology. And the assay that is used most effectively is the Veridex cell search assay. Now, CTCs differ from cytology because it is based on the detection of these cells that is made possible by EpCAMs, or epithelial cell adhesion molecules. And these cells are usually DAPI positive, anti-cytokeratin positive, and CD45 negative. So we get rid of all the white cells. And this is how we get a very specific clone of cells, which are known as circulating tumor cells. Melanomas, which actually spread to the brain very, very often, the high molecular weight melanoma-associated antigen, or the melanoma chondroitin sulfate proteoglycan, which is the MCT, are detected very, very easily in the CTCs. And if you compare the sensitivity of CTCs versus cytology, you will see that in cytology, the first LP had a sensitivity of between 44 and 67%, so about 50%. And on the second LP, it's a bit larger. It's a bit better. It goes up to 91%. But the sensitivity with an LP for CTCs is much higher. It goes up to 100%. I think 100% is only in a very small number of studies that have had very small number of patients, but even then, it is a start. We think that with CTCs, the sensitivity and the specificity is probably higher than the rest. And these are the studies that have come out, almost 10 years ago. Subira et al., which is the third study on this list, published a study of 78 patients, where there was a clinical suspicion of tumors, and she found that with CTCs, the specificity and sensitivity was very high, as with cytology, but with sensitivities, you see the sensitivity of cytology has never been more than 65, 66%. So if you see it, it's probably good, but if you don't see it, then you worry about what's going on. Subira et al. Used flow cytometry again, to publish probably the largest series still there, where she looked at epithelial tumors with metastatic disease, and she found, again, specificity and sensitivities in CTCs was about 80%. And there was a huge difference in the specificity and the sensitivity where we use cytology, where the sensitivity wasn't as good. So if you got a negative test in cytology, we still didn't know what to do. I guess that is still a problem. That remains a problem where it comes to CTCs, and I will get to that in my next slide. There have been several studies, but these are the sort of the larger studies, and there have been a few that have used cell search, which you can see on the second study, where Lin et al., is a Chinese study, used to used CSF and tried to figure out metastatic disease in lung and breast cancer, and we find again, the sensitivity of CTCs is far greater than that of cytology. So other than these sort of studies, there are several others which have far lower number of tumors, and I think they actually really need few more samples to say what they're saying. So CTCs, right? They've been around for a while. We know about cytology. We are now harnessing the power of cytology in a different form. And one of the things that we can do with CTCs is that if we can harvest CTCs in a manner that is used in clinical practice, we can show that the tumor is mutating, and that there is clonal evolution. That is possible on the basis of CTCs. And now with single cell genomics coming up, CTCs has certainly opened up this whole new vista of cancer biology, where we can actually tell you the entire pattern of mutations as the tumor evolves over a period of time. But one of the problems with CTCs, and this is one of the reasons that CTCs actually fail in primary brain tumors, which is gliomas, is what happens if EpCAMs are not present, if we do not have the epithelial molecules that actually define the CTCs, what happens then? A lot of the EpCAMs are actually lost when you have epithelial mesenchymal transformation. And actually in gliomas, which is sort of my sort of area of work, we do not see them. And that is why the diagnosis on the basis of CTCs in gliomas has always been difficult. And the number of studies we still have is not very big, so we can't draw any conclusions from where we are. But the other major clinical problem is that nothing is 100%. So if we do a lumbar puncture, if we do a blood test or whatever we might do, and we have a negative test, what does that mean? Is it a true negative? And I think some of the risk for this can be mitigated if we sort of use multiple modalities, and I'll come to that later. Maybe, in clinical practice, it's not only the CTC, maybe it's a mixture of CTCs and cell-free DNA along with exosomes, etc., etc. What the final picture is, we still don't know, but maybe there is something to say that, yeah, we will need multiple modalities to come up with a definitive answer. And actually now cell-free tumor DNA or ctDNA is the flavor of the month, okay? It can be collected once the tumor is removed, so we can get longitudinal studies from it. We can follow them up. We can do whatever we want, and it is possible to sequence the entire tumor genome piecemeal. So, if we are good enough to identify the little pieces that carry the mutations that are in the bloodstream and have come from the tumor, it is possible to put together the entire tumor genome based on a biopsy that is not invasive, right? And free tumor DNA is present, in abundance in the CSF and also in the blood. So both in the blood and in the CSF, we get a lot of tumor DNA, which can be analyzed. And we are now getting a lot of companies who are coming up with these cell-free DNA assessment kits. Okay, I think MSK, along with Sloan Kettering, had come up with an MSK Access kit, which is, I think, approved by the New York Medical State Association, not yet FDA approved as far as my knowledge goes, but it's happening. So there are a lot more tests that are now clear approved and are being used, but I think it's a matter of time before cell-free tumor DNA becomes one of the ways that we detect metastatic disease. And if we really look at it, we are now using this technology for EGFR mutations in lung cancers. We are looking at KRAS mutations in colon cancer. So this is already there in clinical practice. It's not there in our neurosurgical and neuro-oncology realm as yet, but I think it is just a matter of time before we have enough data to say, yes, liquid biopsies is going to be a part of neurosurgical and neuro-oncology care. One of the things that happens with cell-free DNA is that we do a very targeted sequence. So the problem in doing targeted sequencing is that we might detect the mutation that we're looking for with a fair degree of sensitivity and specificity, but we might miss the elephant in the room. We might miss a large translocation that is driving the tumor. And that is actually something that is difficult, and that doesn't have an answer as yet. But we do not know till now. I don't think there are any studies that are large enough to tell us how often do we find an elephant in the room. Is it really required to do that? Okay. But CSF is definitely the way to go if we want to look at tumors as they evolve, because the number of mutations and the specificity and sensitivity of being able to detect those mutations in the CSF is higher than in the blood. And obviously in the leptomeningeal space, we've already seen with BRAF, KRAS, EGFR, and all the other mutations that are now in clinical practice, CSF is what people look at. Okay. Obviously in KRAS and EGFR, we don't look at the CSF because it's mainly in the lung and in the colon. But for CNS metastatic disease, I think the way to go will be the CSF. And here we have quite a few patients, who has had leptomeningeal disease. I mean, numbers are not great. I mean, in the 40s, and we find that EGFR in non-small cell lung cancer in CSF, and we have a 92% detection rate. Okay. So I think if we have a very targeted mutation that we can sort of figure out, then I think the specificity and the sensitivity rates go up very much. Okay. But if we don't, then we have a problem. And on the third slide, you can see that in the plasma, and that falls to about 55%, but he had GBMs along with breast cancer and lung cancer. So he had a sort of a mixture of tumors. And this is the other thing, right? So if we do not know where the MET is, okay, if we do not know where the primary is, then what do we do? Then we have, a much larger net that we need to spread. And what happens then? What happens to if it comes back negative? So there are a lot of questions, not so many answers as yet, because I think we're just at the tip of the iceberg. What we are doing today is probably only about 1% of what we can do, and as technology evolves, I think we will be in a state to define this better. So there are obvious limitations, and I talked about this a bit earlier, is that targeted sequencing misses other obvious mutations, gene fusions, and copy number variations that are obvious on tumor sequencing may not be detected, right? And the other thing is, we are looking at very small quantities of DNA. So do off-the-shelf sequencing approaches work? Well, we don't know that as yet. And I think with exosome, we are finding that increasingly that we are having to reset the boundaries of what is positive and what is not. And the pre-analytic guidelines of how the tumor is processed, what we do with the blood, how long the blood actually lies outside before it is processed, I think every bit makes a difference to how accurately we diagnose tumors. Now, exosomes is something that's very close to my heart because, this is something that I work on, but it's mainly in the area of gliomas, okay? And these are endovesicles. The first exosomes in gliomas was described in about 2007, which is about 16, 17 years ago now. And these are a subtype of endovesicles, which are 30 to 150 nanometers in size. They carry a cargo of everything, DNA, RNA, protein, and everything else. But one of the major things in exosomes that is beginning to be reported is that tumors markers that are normally up and down regulated in the tumors is actually not represented in the same way in the exosomes, especially if there is metastatic disease. And we find that with STAT3 levels, right? STAT3 levels are high in patients of melanoma who have metastatic disease, but not if you have brain mets. So if you have brain mets, then the STAT3 levels will fall. Similarly, we have looked at P10 levels in exosomal cargo. And paradoxically, this is in GBM patients. If we look at P10 P10 mutated levels of the tumor, they're probably completely absent, or we can hardly see them, but they glow when you see them on the exosomes. We have sort of published our first initial paper, and I think there is some amount of work that is going on right now in trying to figure out what happens to P10, but a number, and we are actually, spreading the net now to see if that happens to all the suppressor genes, whether this is some kind of way that the tumor actually gets rid of the suppressor genes. And I think it's a very important area, a very, very interesting area. I do not have all the answers, but maybe in a few years we will do. But this is why I wanted to talk about exosomes, okay? Because this is something that we did not expect. I did not expect, and I thought initially that the results that we found were false, but they're not, okay? And this is just, one slide that shows if you do a clustering analysis of just glioma patients across the board, okay, we find that there is a fair amount of clustering between the oligos on the ends and the GBMs and the other the astrocytes in the center. So this is an exosomal data, and this will get published, I'm hoping, soon, so watch this space. And this is not actually metastatic disease, but I wonder whether we will get such separation in exosomes if we do the RNA sequencing or a total RNA of exosomes with people who have, say, melanoma with brain mets and melanoma without brain mets. And I think we probably will. And this is something that I think needs to be investigated in future. So before we have liquid biopsy as a clinical entity, I think validity needs to be established, both analytical, clinical validity, and utility. We need to show that people who have the test actually improve as a result of the test, okay? And there are a lot of potential uses, whether it's in diagnosis or in follow-up or in prognostication or even in screening. I know screening is slightly controversial when we come to brain tumors because of what we see with the prevalence and incidence rates, but maybe in high-risk populations, it may be something that we look at. And obviously, for clinical integration, we will need the regulatory clearances. We'll need it to be incorporated into our treatment guidelines. Reimbursement everywhere in the world, whether you're state-funded, self-funded, or insurance-funded, and incorporation into local workflows. So I think every department everywhere around the world will have to be able to do this, right? Which means a lot more human resources, a lot of infrastructure. And that is always an issue, especially where I come from. But I think now it is an issue all over the world. So I will end with that and say thank you. And I will be happy to take questions either now or a bit later.
This was just a great talk, Dr. Ray. We did have one or two questions within the chat, but just in the interest of time, we're going to hold on those until the end when we have our panel discussion, if that's okay with you.
So I would like to next introduce Dr. Jeffrey Weinberg. Dr. Weinberg is a professor of neurosurgery, deputy chair and vice chair of clinical operation at the Department of Neurosurgery at MD Anderson. He also directs their intraoperative brain tumor program. And I have known Dr. Weinberg since I was a medical student at Baylor, and he was a junior faculty at MD Anderson. So I have known and followed his career for quite some time. He's a world-renowned neuro-oncologist with extensive clinical and research experience in surgical management of brain mets. And today he's going to talk about a new clinical trial that he started with gamma tiles. So I'm really excited, Dr. Weinberg.
Wow, it's you can hear me, you said?
Yes.
Yep, we're good.
Excellent. Well, it's so great to see you. It's you know, it's been a long time since you've been here, and even though you're a med student, the group still feels like they had an impact on your training and motivating you, and it's really good to see you succeed and put together something like this. So congratulations.
Thank you.
All right, so I know I'm a little bit out of order, and you're going to have some more talks about this a little bit later on, but what I'm going to talk about is metastatic disease a little bit and talk about brachytherapy using gamma tile, which is a new iteration of a cesium-131 seed for management of metastatic disease, and then give you a little bit of an update in regards to our clinical trial that we're doing. It's a multi-institutional clinical trial for metastatic disease. But let's go through a little bit of the history, because I think it's important as you tell the story of metastatic disease, radiosurgery, the challenges we've had, and I think more importantly, this is a good description of how innovative neurosurgeons are as a group, and what we do when things just don't appear, when things appear to be good. And I know the enemy of good is better, but we keep trying to improve upon things that we have, and I think this is one of those really good examples of what we try to do. So go a little bit into the history of resection and radiosurgery, then give you some description of brachytherapy and the various iterations of that, and then talk about where we are with this clinical trial and what we're trying to achieve. So predominantly our use of radiosurgery with metastatic disease and surgery is based on this trial, which we completed and published in 2017. And this trial was born out of the fact that there was, at that time, a lot of people, us included, who were saying, all right, you know what, let's remove a tumor. We know that there's a recurrence rate that's based on size, it's based on histology, it's based on the fact that we can't always be aggressive with going after margins. So let's apply logic. Let's do radiosurgery to the walls of the resection cavity and figure out if we can improve the local recurrence rate from where it was. So this was the phase 3 trial that we did, where we randomized patients with metastatic disease who were scheduled to undergo surgery, and it had to be a gross total resection based on imaging. You can see the groups were evenly split. Looking at the left side of the slide, we randomized 132 patients that were essentially equally split towards the observation group versus the radiosurgery group. And the key slide, actually there are two groups of outcomes I want to talk about. Just one on the left is the freedom from local recurrence. So I think that was pretty apparent that the radiosurgery added after resection improved the local recurrence rate from 43% to 72% in the radiosurgery group, which was really an outcome that I guess people expected, because again, we were doing it logically, but it had never been really proven until we did this trial. But I think just as important is noticing the other results that we had, which was the overall survival and the freedom from distant brain recurrence. So I don't think anybody ever expected that without whole brain radiation we'd ever protect the brain from distant recurrence, but the overall survival also was not changed. And this actually mirrors all the literature going back on whole brain radiation, that whole brain radiation is definitely used to present distant brain recurrence, and overall survival probably not impacted by that at all, that this is really a function of the management of the systemic disease and whether or not we can prevent brain recurrence later on. The other thing that's interesting is the impact of whole brain radiation on cognition. And so this was done by Eric Chang, who was at our program before moving out to chair the program at USC, and Christina Myers, who started the neurocognition, neuropsychology program at MD Anderson many years ago, where they took patients with brain metastases and treated and looked at a randomized control trial of radiosurgery or radiosurgery plus whole brain, where we looked at the neurocognition over the course of time. And if you see on the left the schema for the trial, we had 58 randomized patients and about 28 on one group and 30 on the other. And it was immediate that we noticed the rate of decline in the radiosurgery plus whole brain, that we had an early stopping rule that was triggered at I can't remember when it was, but essentially we realized that by 4 months, the rate of cognitive decline with the addition of whole brain radiation was so significant that their total recall, delayed recall, and so on was noted to be significantly worse. The whole brain radiation group had a shorter time to death versus the radiosurgery group, but local tumor progression was actually boosted by the addition of whole brain radiation. So I think this implies that, number one, quality of life becomes pretty significant when we're talking about these patients, and the addition of whole brain decreases from that if you suggest that neurocognition impacts quality of life, which all of us believe to be true, and that with the multimodality treatment that we have, and this is even pre-immunotherapy and targeted therapy being used now for brain metastases, that we have multiple options and that we can treat these lesions as they recur and so on. So we are now withholding whole brain radiation. It hasn't necessarily percolated through to the entire radiation oncology department, but essentially if a patient gets referred to the neurosurgery or the CNS radiation oncology clinic, whole brain radiation is the last treatment being used. So let's delve a little bit into brachytherapy for those of you who haven't seen it. So this is a cancer.gov publication. This is their definition. You can go to Wikipedia, you can go to Google, and you're going to essentially get the same definition. So brachytherapy is a type of radiation where you put the material in needles, seeds, wires, catheters, and you put it directly in or near a tumor. You can call it implant radiation therapy, internal radiation therapy, or radiation brachytherapy. I think the point is that this is a technique where you need surgery, and you need to implant this at the time of an operation, or if you're implanting it directly into the tumor through some sort of infusion is being done with a material called rhenium and liposomal nanoparticles. But essentially you're getting the radiation rather than from outside, such as with radiosurgery or external beam or whole brain. You're putting this actually right at or in the tumor. And so the current source that we're using is cesium-131, and I hope nobody asks me about the physics of this, because I think going into neurosurgery was easier than learning about radiation physics. There's a shorter half-life than other materials, and in the past, historically, iodine-125 was used. The problem with, if you look through the literature of the iodine data, is that there really was a lot of radiation necrosis which was generated by the iodine. So cesium-131 deposits the energy in a shorter period. A lot of the dose goes over a shorter period of time, and it's stretched out where you essentially give all the dose within close to 2 months. And it's more homogeneous in the way that the radiation is delivered. And so you can see in the different charts I have up here, the dose rate for the cesium is about 32 centigrade per hour. So it deposits most of its energy quickly. The half-life is about 9.7 days. And so the advantage of all this is that we think that there's improved cancer control rate with faster resolution of short-term side effects and decreased risk of late complications. And there's actually history with the use of cesium. So this is Ted Schwartz and the group from Cornell, who had a lot of experience using, you'll see it's called isoray. I have a picture on one of the next slides. So they used cesium-131 brachytherapy in a prospective trial for large brain metastases, where once the tumor was resected, they laid their cesium against the cavity, and they had 100% freedom from progression at about 12 months with no impact on lesion size. And that's actually very interesting if you think about it, because the larger our tumors, the more we tend to drop the radiosurgery dose when we're giving radiosurgery, and actually that also carries over with our resection cavities. And with this, because you're laying this in at the time of surgery, you don't have to worry about those side effects as much, because it's every piece of the resection cavity is equal and getting an equal dose. So that was for metastatic disease. This is the similar group of people out of Cornell used cesium-131 seeds for recurrent glioblastomas that were amenable to surgical resection. The nice thing about the cesium is that it deposits the energy at no more than 5 millimeters from the wall of where you placed it. So actually that leads theoretically to less radiation necrosis. And if you look at the results, which I highlight on the right, there's a recurrence at about 7 months. Median survival is 9 months, which is not bad for a recurrent glioblastoma, going out to 26 months. No radiation necrosis, which is in sharp contrast with the experience with the iodine material, and typical recurrent risks of superficial infection and seizures. So it really seemed to be beneficial. Now I want to point out the one thing that's important about this. I don't think anybody should expect that brachytherapy is going to be the cure-all for glioblastoma. We have to remember that glioblastoma is an invasive disease, that beyond the 5 millimeters that the radiation from brachytherapy can reach, there are still tumor cells. And this may just be for the properly selected patients who have a small nodular recurrence amenable to surgery, and not the phenotype, which is remarkably infiltrative, almost a gliomatosis type appearance. This is really more for a local recurrence similar to metastatic disease. And I would think of it, you need a target that you're going to remove, and then this would line the wall of the cavity to treat that cavity. So the tiles that I'm going to talk about are really not the only technique that's being used now. This is kind of like a microscope. I think Zeiss is putting this out. And if you see the ball at the end of the instrument, this actually, you would do a resection and then slip that ball into the resection cavity, and this would apply brachytherapy prior to your closing. This is the isorate seeds, which I mentioned. This is a vicral strand, and within this vicral strand, there are seeds which you can't see, but at least in this picture, it's nicely oriented along the wall of the cavity, equal spacing, and so on. I think what happened in speaking with people who use this is that the sense was that these strands didn't really adhere to the wall. And so what would happen is that over time they would drift closer to each other. Maybe this would fall down because of gravity and fall off the wall. And then you would end up with hot spots where you might have two seeds next to each other, giving too high a dose, or you might have cold spots, conversely, where you didn't get enough dose at all. So the tile that I'm going to show you was created to be an improvement upon this technique. And so if you haven't seen it, this is what the gamma tile looks like. This is a 2 centimeter by 2 centimeter, essentially Duragen patch with, it's hard to see, but these are the seeds that are oriented within the square tile. They are a vicral strand, similarly to the isoray, but they're put within this collagen tile, which theoretically sticks to the brain better than the strands that I showed you earlier. In order to make the dose a little bit more homogeneous and to avoid some of the hot spots that I mentioned earlier, you can see that the seeds are offset from the bumpy side of the tile closer toward the flat side of the tile. So as they remind us, you put the bumps to the brain, and that allows this greater distance to create more of a homogeneous dose. And this is now FDA cleared for malignant brain tumors, primary and secondary, for newly diagnosed and recurrent disease. There's been really no increased risk of adverse events from doing this, not certainly different than the traditional surgery. About 8% radiation-related brain changes, which seems to be lower than the other techniques. These are the surgical events, so surgery plus collagen tile therapy, about 2.5%, wound issues, dural issues, or surgery-related hematoma, which is unlikely to be from the actual tile itself. And this is, I think the wound issues are significantly less than external radiation, or at least equal to, because one, it's not real, this really doesn't have a bearing. So in contrast, or similarly to just recurrent surgery in general, we have poor wounds, we have skin that may have been radiated. I don't think the radiation dose gets out far enough that it has much bearing. So let me get a little bit into this trial that we designed. We've called it the Rhodes trial, Radiation One and Done Study. Everybody needs a fancy name to attract attention. So that was our trial name, or is our trial name. And so the questions we're asking is, can we get better local control after resection, at least equivalent to radiosurgery, if not better? Can we make, does this type of technique, the brachytherapy, cause less radiation necrosis than radiosurgery? And is there potentially a benefit to neurocognitive function using brachytherapy compared to radiosurgery? So that's the hypothesis. The objective is to compare surgical tumor removal followed by radiotherapy using the brachytherapy. And then we estimate to take 18 months. It's probably going to take us a little longer than that. We hope to follow the patients out over 2 years. Interim analysis at about 35 events with the final analysis at 70 events. Here's our primary outcomes. That I already mentioned, but we're also looking at overall survival, quality of life, neurocognitive function, functional status, other delays that might cause radiosurgery, looking at adverse events, duration of hospitalization, also leptomeningeal dissemination adjacent to the surgical bed, and follow-up 2 to 3 years, as I mentioned. Here's our inclusion and exclusion criteria. We've limited this to patients with 4 brain metastases, where at least 1 is planned for surgical resection. The rest can be treated with radiosurgery, which is expected, whether or not the patient was randomized to the gamma tile or radiosurgery. Good performance status, presumed prognosis of at least 6 months or better, and we'll stratify them by age, number of mets, size of the lesion, histology, and so on. And then the exclusion criteria is any past radiation therapy, or if you had a total of 2 courses of radiotherapy treatment to previous lesions, as long as you're greater than 15 millimeters from the index lesion, then you actually can still be included. Any tumor that's deemed to be severely radiosensitive is not included. Presume no LMD, and if you've had prior whole brain, you're not included. So we figured out that we have to power this by using 180 patients. I mentioned the outcomes in the analysis, and here's the general schema for the trial. Essentially, we identify a patient, we randomize them, get a surgery date. They have to have their neuropsych testing before treatment, and then they get randomized, and we figure out, we then enact the protocol accordingly. Here's where we are now as far as the enrollment is concerned. We're up to 15 patients since I put this slide together. I think the rest are the same. And we've actually have a bunch of other sites now on board who are participating in this clinical trial. I don't know how many of you have seen gamma tile or performed brachytherapy, but this is how it works. We identify a patient, we let the radiation oncologist know, we do a scan. Now, the pre-op scan prior to surgery is used for the dosing, and also helps the radiation oncologist and the radiation physicist order the appropriate number of tiles to fill the cavity. I will tell you that they are expensive, and wasting tiles really irks me, because I know it's a cost that the hospital has to eat. Once they're a tile, we schedule surgery. You need a minimum of 4 days in advance to order the tiles. The radiation oncologist consents the patient for the radiation, and we consent them obviously for the surgery. Here's a patient not on trial, but this is a patient of mine who had, I think he has colon cancer, and these lesions have all failed radiosurgery. And you can see even this one has a little bit of subdural, or actually this was even dural extension. We ended up taking him for, believe it or not, a multiple craniotomy to remove these lesions, and we reinforced all of them with the Cs. And I show this not to show you the crazy stuff that sometimes we're asked to do, but more to show you what the imaging looks like after the operation. This is the MR appearance of the seeds in place, and you can see the little metal seeds within the brachytherapy tile. On CT, they show it much better. And it's actually afterwards that the radiation physicist and the radiation oncologist then determine the dosing to the cavities. I show this just to give you an idea of the technique. Tom Beckham, who's our lead radiation oncologist, who's involved in the brachytherapy program, puts this little dot on there. This is a reminder that as we place them in the brain, we want to see the dot. You put the bumps toward the brain and you see the dot, and that helps to ensure that that offset, which I showed you on the tile, is appropriate for the wall of the resection cavity. Let me see if I can run these videos very quickly. I'm pretty sure I'm running out of time. So this is what the tile looks like. You can cut it in half if you're worried about the size of the resection cavity. Video's running a little slowly, but this is really all it takes. There's really no time in doing this. The big learning curve is getting the radiation team and the physics team, who are not used to working in an OR environment, I'm sorry that's not running smoothly, to come up to the OR. The other small little technique issue I'll point out is that we have the dura ready to be closed. So once this is on, people are afraid of radiation, but as I mentioned, the energy it generates doesn't go much beyond where you're placing it. So they give you a long forceps and so on, but after this we close the dura. Once the bone is on, the dose attenuation outside of the bone is significantly decreased. Other little tricks include folding this in half before you insert it. And then once, let me pause this and see if I can get it to catch up. Just then you fold it, and then you can get it against the wall of cavity. Our typical experience has shown that we put it along the bottom first and then do the wall. So you get your hemostasis, you put this in, and then you're done. The other thing I'll point out is if you notice the ring that I'm wearing, this is the same radiation sensitivity device that you wear on your coat. This is a ring badge that you put on, that you wear with you, so the safety team can measure your exposure to radiation from this procedure. And essentially that's it. It's put into position and you close and you're done. The amount of time that goes into this is really minimal during the actual surgery. Here's our team. There ended up being a lot of people involved in the clinical trial, as you would expect. Research team, biostats team. Couldn't do this without the radiation oncologist. Mary Fran McAleer was critical in helping generate the protocol. She's now the quality officer for the entire division of radiation oncology. So passed this trial off to Tom Beckham, who actually was the only person who had an experience doing this, and he's now helping us with all our patients. Rajat is just absolutely outstanding from the analysis, the physics, and the safety perspective. And then all these other people were germane in the clinical trial and identifying patients. I should mention that there are other clinical trials which are pending. One for newly diagnosed GBM, where there will be brachytherapy plus the brain radiation, maybe even tumor treating fields, if you do that in your practice. And then surgery plus GammaTile versus surgery alone for recurrent metastatic disease. And again, all these looking at the added benefit by the by the brachytherapy tile, as well as the incidence of radiation necrosis. And so I think with that, I'll end my talk and am happy to take questions now or whenever you'd like. Thank you.
That was a great talk, Dr. Weinberg. If you don't mind, we'll move to the next speaker, but if you can hang out, we will have questions during the panel discussion for you.
I'm here.
Thank you.
Awesome. And with that, I would like to introduce our next speaker. She's a rising star in radiation oncology, Dr. Namita Agrawal. She's an assistant professor of radiation oncology at Indiana University. Her clinical and research interest lies in management of brain metastases. And I have the privilege of knowing her since she was a resident. Again, it's a theme. Sometime I was a resident, sometime other people who are resident. Now she's a faculty. This is a clinical trial that she's spearheaded when she was a resident, and now she's bringing it to fruition as a faculty at Indiana University. So you're ready.
Thank you so much, Dr. Day, for that introduction. Huge credit to you, especially with the collaboration between radiation oncology and neurosurgery. It takes multidisciplinary collaboration to really get the ball rolling and improving quality of care as well as treatment outcomes for our patients. So definitely a huge shout out to you. Previously, Dr. Day was at Indiana University. So I am going to go ahead and share my screen here. And you guys are able to see that okay?
Yes.
That's great.
Okay. So I am going to be talking about preoperative stereotactic radiosurgery, followed by resection for patients who have a limited number of brain metastases. As Dr. Day mentioned, I am currently an assistant professor of radiation oncology. I'm specifically the medical director of the Shores Cancer Center branch of the Indiana University School of Medicine. And I have no disclosures. So we are going to learn a lot today about the evolution of brain metastases treatment. Dr. Asher, who we will hear from later today, is going to additionally be talking about preoperative and postoperative radiosurgery. And so we will be hearing more from him. But what you'll see is that initially, the treatment for even just one brain metastasis was to perform whole brain radiotherapy. We moved away from that to understand the utilization of surgery for these patients, and then further moved to surgical resection followed by whole brain radiation. And now we are exploring the options of combining surgical resection with radiation therapy, whether the radiation is performed after surgery, which has been our standard for many years now, or if radiation is performed using something like gamma tile that we just heard about, versus doing radiation even before the resection happens. Really, the implementation of radiosurgery is credited to Dr. Lars Leksell, and he was a Swedish professor of neurosurgery. He was the first to describe the concept of stereotactic radiosurgery in 1951, although people had been working on radiosurgery prior to that. Radiosurgery is essentially using a very focused dose of radiation that is considered ablative, or enough radiation to wipe out the tumor cells. And that's what I will be focusing on today. So while post-operative radiosurgery has significant advantages over post-operative whole brain radiation, which again, we'll hear more from Dr. Asher about that, and the main reason for that is because of decreasing cognitive side effects. there still remain some limitations of using postoperative radiosurgery. And so here, I am just going to run through some of the kind of the drawbacks of cavity radiosurgery. So Dr. Soltis at Stanford in 2008, he published a retrospective analysis of 72 patients with 76 surgical cavities that was treated with postoperative radiosurgery. As part of his analysis on univariate, he noticed that an increasing conformality index predicted for increased local control. So what's conformality index? Essentially, it is the amount of tissue that is receiving the full dose of radiation divided by the amount of the target volume that is receiving the full radiation dose. So most of us would think that a conformality index of 1, meaning the amount of radiation that you're prescribing only surrounds your target volume, would be ideal. However, what Dr. Soltis found, and you can see in this graph, is that as the conformality index increased, the local control at the cavity increased. And so essentially that's saying that if we have the radiation dose maybe out to this red area, as opposed to at the green area, we may get better local control in the postoperative setting. Dr. Akanda in 2019 performed a systematic review and meta-analysis of using postoperative stereotactic radiosurgery. And this included 50 studies with about, I want to say about 4,000 patients, and demonstrated a 7% rate of radiation necrosis at the surgical site. So radiation necrosis is one of the main side effects of using radiation in the brain. It can mimic the side effects that were initially present at the time of when a tumor was at that place where the surgical resection cavity was, because essentially the radiation kind of creates dead cells, and therefore that part of the brain may not function. This study, or the systematic review analysis, demonstrated a 7% radiation rate of necrosis, but an earlier study really demonstrated that the rate of radiation necrosis is likely underrepresented. And the reason for that, it's hard to diagnose. I have a set of images here on the right-hand side, and in image B, you see what looks exactly like a tumor. It has this white surrounding it is called vasogenic edema, also very common to see in brain metastases. This is just another slice of that area of the lesion. D is a newer imaging technology that we are starting to have more and more available to us, which is called a FET-PET MRI. Now this takes a radio-labeled amino acid, and it that when you perform the PET scan, areas that have tumor cells light up because that radio-labeled amino acid is taken up by tumor cells. When you overlay that on top of an MRI scan, if an area is expected to be tumor, you would think that that area would light up bright. So this is now being increasingly used to try and help us differentiate whether something is necrosis versus tumor. You can see here, this image is roughly the same slice as these images. And in the area where you see this lesion in the brain, you do not see anything light up. And so that would be more consistent with radiation necrosis. Now, truly the only way that we can diagnose radiation necrosis is to remove this area and then look at what was removed underneath the microscope. But that's highly invasive. And so this is a radiographic way that we can try and make that determination. But 10, 15, 20 years ago, without the availability of these newer imaging types, it's very difficult to differentiate the two. And then Dr. Adler in 2013, he looked at 165 patients that were treated with postoperative radiosurgery without the use of radiation to the brain beforehand, and using a dose range of 15 to 24 gray. They did add the 2 mm margin for patients that were accrued after 2007, and that was because of Dr. Soltis's findings. And what they found was that 13% of patients developed what's called leptomeningeal disease at a median of 5 months. And so with leptomeningeal disease, essentially you can see that this bright white that is kind of coating everything that's in between the gray matter, and that is where the leptomeninges are. And so that bright white is actually indicating that there is disease kind of caking the leptomeninges. Interestingly, the 1-year cumulative incidence of leptomeningeal disease was the highest in patients who had breast cancer, and that was recorded at a rate of 23.5%. And then talking about local control. So how does cavity radiosurgery do? Dr. Gans again did a systematic review that looked at 14 studies, about 630 patients treated with radiosurgery after surgical resection. They noticed that 6 out of 14 studies used that additional margin around the surgical cavity, perhaps related to increased local control, and 4 studies did not state whether or not they used an additional margin. In that systematic review, the pooled crude mean local control rate was 83%. A retrospective analysis that was conducted by Dr. Scheitler-Ring in 2016 looked at 83 patients who underwent surgical resection of the brain, and subsequently that was followed by either radiosurgery or whole brain radiation. And what they found was that the local recurrence rate was 34% in the patients who had cavity radiosurgery. And then recently, Dr. Mahajan published a phase 3 prospective clinical trial where patients were randomized who had 1 to 3 brain metastases with complete resection of at least 1 metastasis to either postoperative radiosurgery or observation. And what the study found was that the cumulative incidence of local control in the postoperative radiosurgery group at 6 months was 83%, and at 12 months was 72%. So what are some theoretical advantages of performing radiosurgery not after the surgical resection, but before, so preoperatively? So a couple of thoughts there. The ease of delineating the target. So if we look at the images that are on the right-hand side, the top image here shows the resection cavity. Now, something that we are very familiar with in the radiation oncology world is that it can be challenging to define the target. When looking at this MRI scan, it's kind of difficult to tell how far anteriorly do you take your target volume, how far laterally. There's always questions about, do you include the resection bed tract? And if you compare that to the image that's on the bottom, these are intact brain metastases. As you can see, and most commonly, brain metastases are very well circumscribed. You can kind of see a border between the brain metastasis and the surrounding normal brain. And therefore, it is easier to target the intact brain metastasis over the resection cavity. Another theoretical advantage is the possibility of sterilizing the tumor edge. So when a surgeon goes in and removes the tumor, they of course have to perform very, very intricate dissections. You do not want to obviously remove normal brain tissue, and so they're dissecting down to the plane of where this tumor is and where they see normal brain. Now, it's possible that when they then remove the tumor, that some of those tumor cells that are right on the edge of the cavity may microscopically get spread around in the cavity, and there would be no way to know that with the naked eye. And so if you do radiation prior to surgery, there's a possibility that the radiation could make those tumor cells that are on the edge of the tumor non-functional, non-viable. And then when it is removed at the time of surgery, even if those cells were spread around in the surgical cavity, they may be non-viable, and so it wouldn't affect anything like local control or other types of patient outcomes. And then a radiobiological potential advantage is that prior to having surgery, there is intact peritumoral vasculature, and therefore the oxygen content is intact around the tumor. So why may that help? Well, for X-ray based radiosurgery, the radiation dose that is administered if there is no oxygen, so in a hypoxic conditions, versus oxygenated or aerated conditions, has to be 3 times as high to achieve the same biologic effect. And that's because the way that X-rays produce damage to the tumor cell DNA is that for the vast majority, for 2/3, there's a production of free radicals. And that free radical is actually what then subsequently leads to the DNA damage. Now, oxygen, what it can do is it can stabilize the damage potential of the free radicals. And so oxygen is important to making the radiation work better. And so theoretically, in the postoperative setting, when the tumor environment has been changed, maybe some of the vasculature has been removed or is otherwise non-functional, we may be limiting the potential biologic effects of the radiation. So we came up with this idea as a field of preoperative radiosurgery. Again, Dr. Asher will be presenting both single and multi-institutional data for preoperative radiosurgery. So I'll leave that majority of the discussion to him. He will use a combination of prospective and retrospective data. But this is the analysis that Dr. Asher put together himself and is one of the first published series of using preoperative radiosurgery. And so how he did that was he essentially, they had a group of patients who were treated with preoperative radiosurgery, and then they combined that into a prospective protocol where patients were then prospectively enrolled onto their trial. They had a median follow-up of 12 months in their study that was published. And the median time between when the radiosurgery was performed and when the surgery was done was 1 day, but that ranged from 0 to 17 days. And they noticed that there were 8 local failures. 6 of those failures had what they deemed as broad surgical or broad dural attachment. And so what I wanted to highlight in this chart below is that at the time point of 6 months, the local control was very high. It was 97.8%. At 12 months, it was 85.6%. And at 2 years, it was 71.8%. The overall survival didn't change. It was very similar to other published data about using radiation in conjunction with surgery for brain metastases. And then also importantly, their rate of radiation necrosis. So they did not see that in this study, and leptomeningeal disease, they also did not see that in their study. So as Dr. Day mentioned, we collaboratively opened a trial at Indiana University called a phase 2 study analyzing preoperative stereotactic radiosurgery followed by resection for patients with 1 to 4 brain metastases. And I have the clinicaltrial.gov ID down below. And this study was a prospective single-arm phase 2 trial that was created to determine the local control or the control at the surgical resection site at 6 months, utilizing preoperative radiosurgery followed by surgery within 1 to 4 days. And this was performed specifically for patients that had a diagnosis of 1 to 4 brain mets and an indication for surgical resection of at least one of those brain mets. The primary objective of the study was 6-month in-brain local control. And so local failure was defined as recurrent or progressing tumor within the planning target volume or the surgical resection cavity on any post-treatment MRI. Secondary outcomes included overall survival, which was the time from treatment start to death of any cause, the rate of in-brain progression, which was defined as the proportion of patients with disease progression inside of the brain, which included both local failure and distant in-brain failure, the rate of leptomeningeal spread, which was defined as the proportion of patients with leptomeningeal spread, and what that could be diagnosed either radiographically or using CSF analysis. And then the rate of radiation necrosis, which was the proportion of patients with radiation necrosis. And that was the preference there was to use radiographically the PET MRI that I discussed earlier, but biopsy proven was allowed. And then importantly, we have an exploratory analysis, which is to try and correlate tumor biomarkers with these outcomes. So the main inclusion criteria was 1 to 4 solid tumor brain metastases on diagnostic imaging. The patient had to have an estimated median survival of at least 6 months. And a criteria for resection of at least one of those metastases per neurosurgeon discretion. This metastasis could be no more than 5 centimeters in longest diameter. And the total brain metastases volume had to be under 30 cc's, excluding the lesion to be resected. The main exclusion criteria was prior whole brain radiation therapy or radiation to the lesion that was to be resected, receipt of anti-VEGF therapy, which may cause some complications with surgery and radiation within 6 weeks prior to enrollment, leptomeningeal metastases documented by MRI or CSF, and a planned adjuvant intracranial radiation, especially to the site of the resection cavity. This is a flow chart. So patients who had a diagnosis of brain metastases that fit the eligibility criteria as discussed were enrolled on the trial. And their first line of treatment was the radiosurgery. After radiosurgery was delivered, those patients underwent surgical resection of the brain met within 1 to 4 days after surgery. And then the follow-up included obtaining an MRI of the brain using thin cut slices 1 millimeter without any gaps every 3 months for a total of 2 years. And then after 2 years, the patients were allowed to follow up per standard of care. Oops. So a little bit of background on the dose of radiosurgery that was chosen. It was based off of RTOG 9005, which is a very, very common protocol to use to dose radiation in the brain. And the reason is because this study took patients who previously had a treatment with partial or whole brain radiation and had evidence of solitary recurrence that was no more than 4 centimeters in size, or multiple in-brain recurrences with only one dominant lesion that was to be treated with radiosurgery. The study was designed as a dose escalation trial with a prescribed dose based on the tumor diameter. And the radiation dose was escalated based on the incidence of acute CNS toxicity and increased in 3-gray increments. So the maximum doses that were reached were 24 gray in the less than or equal to 2 centimeter cohort, 18 gray in the 21 to 3 centimeter cohort, and 15 gray in the more than 3 and no more than 4 centimeter cohort. So these doses were thought to be safe and effective. So in our trial, radiosurgery was performed as mentioned, prior to surgical resection, and we adapted the doses based off of our TOG 9005 study. And you can see, though, that we have an additional cohort here where the tumor was allowed to be between 41 to 50 millimeters, utilizing the same dose that our TOG 9005 did for the 31 to 40 millimeters. And the reason that we allowed that was because the majority of the tumor or majority of the tissue that was going to be radiated was going to subsequently be removed at the time of surgery. And so therefore, we thought that there would be less of a risk of side effects from performing the radiation, such as radiation necrosis. I mentioned a correlative radiobiologic analysis, and a big shout out to Dr. Day, who is handling and helping with this analysis. So there are no current published reports of the in vivo effects of radiosurgery in the immediate post-procedural setting for human metastatic brain tumor. And so the preoperative radiosurgery paradigm has a really unique opportunity to evaluate radiobiologic effects of ablative doses of radiation within 4 days of treatment. And we know from other studies that tissue radiosensitivity is very dependent on tumor genetics. So it's important to investigate the evolution of the genomic profile after what we consider a clinical ablative dose of radiation, leading to tumor eradication versus resistance or recurrence, and what changes we may need to make. So moving on to the results, the initial preliminary results of our study. The accrual was between 2017 to 2022. There was a total of 54 patients that were accrued. 3 of them were found to be ineligible. 1 was because the patient was ultimately found to have primary CNS tumor. A second did not undergo surgery, and a third was found to have 5 intracranial metastases, leaving a total of 51 patients. So 32 of the patients, or 62% of the patients, currently are deceased to date. 6 of those patients actually passed before their first surveillance MRI at 3 months. 14 passed prior to 6-month follow-up MRI, and before a 6-month follow-up, and 20, or almost 40% of patients, were deceased prior to obtaining a 6-month follow-up brain MRI. But the median follow-up for all patients was 13 months, and for those patients who remained alive was 25 months. So looking at the patient characteristics, the median age was 59, the median performance status was 80, the percentage of patients that was female was 52 or 53%. 60% of patients had a prior diagnosis of cancer, and 47% had prior systemic therapy within 3 months of radiosurgery, and 57% had active systemic disease at the time of their brain mets diagnosis. The most common histology was lung at 51%. About 10% of patients lesions had dural attachment. 37% was located in the parietal lobe, and 22% of patients had posterior fossa location of the tumor that was to be resected. The median radiosurgery dose was 15, which correlated with the median diameter of the lesion being 3.1 centimeter. And then Gamma knife was used to deliver radiosurgery in 27.5% of patients. And the days between radiosurgery and surgery, the median number of days was 1, but ranged up to 3. So looking at overall survival, the reason that we need more and more research into treatment for brain metastases is because, as you can see from this graph, overall survival does decrease, and it can decrease pretty quickly, even for patients that have a limited number of brain metastases and great performance status. And so you can see that here, in that the 6-month overall survival predicted was 72.6%, with a median overall survival of 76 weeks. In terms of in-brain control, the median time to any in-brain recurrence, so whether that was distant or local, was 6.2 months. In this analysis, for patients who passed without having a surveillance MRI performed, they were counted towards an event on the date of their death. And so you can see that the 6-month any in-brain control was 72.6%. But looking at the local control, which was the primary endpoint of this analysis, the median time to local recurrence at the surgical cavity was not reached. The 6-month local control rate was around 96%. 12 months was 90%, and the 24 months was 81%. So comparing that 6-month and 12-month numbers to some of those prior studies that I mentioned that ranged from a 34% recurrence using postoperative radiosurgery up to or down to about 10 to 15% chance of recurrence. And then freedom from radiation necrosis. So also very important to look at the side effects. At 6 months, there was no estimated development of radiation necrosis. And you can see that in total, the rate of developing radiation necrosis really plateaus. At 2 years, it was 81% of patients who did not develop radiation necrosis. And then looking at leptomeningeal disease, so 95% of patients were free from developing intracranial leptomeningeal disease at 6 months, and that kind of plateaued out after the 6-month time period at 92.1% up to 2 years. So we performed univariate and multivariable analysis for overall survival. And I wanted to focus on what was statistically significant. And you can see that breast histology did have an improved overall survival. You can see that patients who had prior systemic therapy had worse overall survival. And interestingly, dural attachment was found to be an improved improved overall survival factor, and more study would need to be done as to what the biologic reasoning for that could be. Looking at local control, so breast histology trended for on univariate analysis towards having a better local control, while patients who had active systemic disease trended towards having worse local control. Nothing was found to be significant on multivariable analysis. And then for any in-brain failure, lung histology was found to have an increased likelihood of having any in-brain failure, while breast histology was found to have an improved risk of developing in-brain failure. On multivariable analysis, lung histology and prior systemic therapy were associated with in-brain failure recurrences. And so in conclusion, and again, Dr. Asher will discuss some of this, patients who present with good performance status and a solitary intracranial metastasis, have an indication for surgical resection of their lesion accompanied with radiation therapy. For patients who present with seizures, symptoms of increased intracranial pressure, and certain other neurocognitive symptoms, resection is indicated to help relieve those symptoms. And so many patients have an indication to undergo surgery for their limited number of brain metastases. We hypothesized that treating these patients with preoperative radiosurgery would improve local control while decreasing rates of leptomeningeal spread and radiation necrosis, and found that the 6-month cavity local control was 96%, the 6-month freedom from developing radiation necrosis at the surgical cavity was 100%, and the 6-month freedom from developing leptomeningeal disease was 95%. Interestingly, breast histology had a lower likelihood of local progression, while active systemic disease had a higher likelihood of local progression on univariate analysis. In lung histology and systemic therapy within 3 months prior to brain met diagnosis had a higher likelihood of any in-brain failure on multivariable analysis, while breast histology had a lower likelihood of any in-brain failure. I'd like to take a second just to discuss future directions. So Dr. Asher will discuss the NRG-BN012 trial. We heard about GammaTile, and so comparison of radiosurgery to implanted radioactive sources at the surgical cavity is a very important area that needs to be studied. And then as systemic therapy changes, the role of radiotherapy and intracranial outcomes will change. And so kind of adjusting systemic therapy, radiation therapy in the future is going to be very important. And I would like to acknowledge Dr. Richard Zellers, who is the chair of the radiation oncology department at IU, Dr. Day, who's a co-investigator, Dr. Huff, also co-investigator, and Dr. Shea. And a special thanks to Dr. Gordon Watson, who was a mentor and instrumental in the development of this study. The research office, the protocol development team, everyone who helped to accrue these patients are all very, very vital to allowing this trial to occur. So with that, I will turn it over to Dr. Day.
That was just a great talk, Dr. Agarwal. Thank you so much. And kudos to you and your team for completing this trial, especially right as we lead up to what is the recently open BN012 that Dr. Asher will talk about later on today. We do have an opportunity for questions now for the folks that have joined us online. Please feel free to use the chat if you do have questions. If we could ask the 4 presenters that had talked to us this morning to rejoin us on the screen, that would be just great. I'd like to start off with one question for Dr. Weinberg, if that's okay. Our own institution has not jumped on board with GammaTile yet. We've taken the route more so of preoperative gamma knife stereotactic radiosurgery for metastases and deliver our radiation up front. One question I had is just with the confound that the seeds could perhaps cause with surveillance. Could you discuss a little bit about the artifact that is seen on MRI scan and if that has caused any issue with picking up recurrences when those seeds are in place in that cavity?
Yeah, thank you very much. It's a really good question. I think the image I showed before, the artifact I think is more prevalent on the CT rather than MR. So the ability to identify contrast enhancement in the walls of the resection cavity over time has not really been an issue. I think probably even a bigger point that you bring up is how to implement this program. It's not easy, and for lack of a better term, it ain't cheap. And that you really need a commitment on behalf of the institution, because I'll tell you, the very first case we did, I think we used 4 tiles and we might have ordered 7. So that there's a learning curve. And the other thing which is also you don't really think about until the time, is that the first nurse who walks into the room is now worried that the patient's glowing and that they can't get near them, and they're trying to feed them their tray from across the room. And it takes the physicist to walk in there with a Geiger counter and show them that there's really no radiation dispersal, even when they get close to the patient. As a matter of fact, I once had them hold the Geiger counter next to the head every time we closed a layer, from the dura to the bone to the skin, and the attenuation from the bone is probably the most significant, and the skin even adds to that even more. And because it's such a quick deposition over time, and even though 90%, I think my slide had 99% of the radiation is done by 2 months, the risk to people adjacent to the patient is essentially nearly zero, even when they're discharged from the hospital. So there is a cost, both monetarily and financially and education, to implementing, but now that it's in place and we've done across using it for recurrent Mets that have failed radiosurgery or whole brain, and for the protocol patients, it's become pretty routine.
That's great. That's great. Thank you.
And I have a question for Dr. Ray. So now that we heard about all these radiation various form of radiation that we're doing with the cavity and the Mets, do you think that will change your exosome? And is there a way to tell the treatment effect based on liquid biopsies and exosome in terms of recurrence versus radionecrosis?
I was sort of thinking that, somebody would have asked me a question about follow-up, and I don't think we have an answer yet, right? So this is anecdotal, and from what we have found is that if you start doing it seriously, so if you do it pre-op and then at operation and then just follow them up, so the volume of exosomes actually change, and the number of mutations change as you go through disease, right? So between radionecrosis and sort of pseudo progression and progression, I think there is a difference as long as we have a pre-op sample and a sample at surgery. I think those two are important sort of important sort of hooks on which we can sort of hook the data, right? Whether radiation actually changes the patterns of mutations or not, I don't know. Okay, I really don't know. I don't have data to support it, but I'm willing to sort of look at it, right? So if somebody's going to say, yeah, be part of a trial, yeah, I'm more than happy, right, to be part of a trial to look at it. And I think, especially in the Western world, I think that is where there is a real a need for liquid biopsy, because it's easily done, and I think it sort of takes the pressure off radiology and having to do an MRI scan and all the things to do with claustrophobia and everything else. So I think there is a real need to do that, and I think we've had some fantastic sort of long-term studies done here, and I think that is something that needs to be looked at seriously. Yeah.
So I can tell you, since we are doing some of the genomic analysis from the trial, the radiation does increase and changes the mutational burden, especially in the periphery where the dosing has a dosing fall off compared to the center. So we will have that data to show that it does change that. And
okay, I think sorry, in which case I think it probably will be mirrored in the exosomes and in the CSA and in the ctDNA. But actually, I don't want to make a comment till we actually have data to show that, and we don't. So
yeah, that's completely understandable.
Looks like Dr. Asher has a question as well. I don't know if we can unmute him. Go ahead, Tony.
I'm sorry for the snafu earlier, so I look forward to talking to you folks in a little bit. I am on call, and so right after this, I'm going to run and see a couple of patients, and I'll come back. But I did want to, I had been exchanging some information with Dr. Ray. All the presentations were phenomenal. And I know that you're traveling, so just in case you did have to leave before I talked, the prospective randomized trial is going to have a correlative component. So the NCI CTEP specifically is allowing us to collect CSF, serum, and obviously the tumors at the time of surgery. As you'll see from the talk, this issue of LMD is a really, really big deal. And hopefully the data is convincing. We literally had to go back to the drawing board 2 years after our original CTEP proposal because they were convinced that this was merely a radiographic phenomenon, and it's anything but. But I would love to touch base with you at some point because my feeling is that we could likely do some very interesting correlative analyses to see whether or not various factors would be predictive of LMD by obtaining some of these biospecimens at the time of surgery. Again, if we're beginning to understand that there are certain manipulations that would change that dynamic, it would be fascinating to understand it better on a molecular level. And the only other thing I'll mention is that we know for a fact from preliminary analyses that there are profound immunopotentiating effects of preoperative SRS. Again, whether or not those would be reflected in the serum or CSF of patients, because we know they're reflected in the tumors themselves, is something that I think would be fantastic to investigate.
Go ahead, Dr. Ray.
It's absolutely fascinating if we could do that long term. And I think also what would be really fascinating is to look at it, sort of longitudinally follow up a patient who is having progressive mets. So you have, a cohort of patients who have, say, a lung cancer with no mets, and lung cancer with liver mets, and then say lung cancer with brain mets, and see if the exosomal profiles actually change. Because I think that will be an absolutely, phenomenal study. Because there's something about brain mets, and there's something about, these. I don't know. I mean, I don't know what it is, but there's something about these exosomes in brain tumors specifically that actually don't sit quite right with our current understanding. I mean, why is the level of P10 so high in gliomas in exosomes? And we are seeing it consistently. We're seeing it at the RNA level. We are now seeing it at the protein level as well, right? So there is something that's going on. We don't know what's going on. Is that what makes it cold? I don't know. I mean, there are so many other things, right? So immunological markers are high in exosomes, but, so I think, to be able to do longitudinal studies across the world, is something that we would like to do. I mean, we have started collecting samples in India, and we did quite well. We've got about 2,000 brain tumor samples now, close to. But longitudinal follow-up is an issue because, people don't come back. And as you know, it's almost all privately paid for. And I'm in a private practice setup. But even then, and government bureaucracy hasn't changed a lot. So we sort of run into problems. But I think if we can, get a global sort of consortium together to do this, and we have a brain tumor consortium now, and I'll be happy to introduce anyone who wants to be a part of that. I think global collaboration is the need of the hour, and I think conferences like this and being able to interact across the globe is fantastic for something like that.
Couldn't agree more. There was one question that came in on the chat, and I'm glad that both Dr. Asher and Dr. Agarwal are still on the call. So is there any indication from the preoperative SRS trials that have been done that the primary location of the brain met makes a difference in the SRS efficacy, or do all mets tend to respond the same?
So yeah, I think that's a great question. We did look at whether the location of the brain metastasis being parietal or in the posterior fossa made a difference in terms of local control and other outcomes. And we did not find that in our study. But that does not mean that there are not differences. I think that we're just hearing kind of Dr. Ray and everyone speaking, we've kind of just touched the surface of what the biologic differences are in brain mets, and is a breast tumor with a brain metastasis in the posterior fossa, is that exactly the same biologically as a brain met that is not in the posterior fossa? I don't think that we have that answer. We do hypothesize that if a lesion were to have an extended dural component to it, that may increase the risk of local failure, especially because it's difficult to tell radiographically then where the radiation should end. We did not find that in our study. I think that's because of the low number of patients that were enrolled that did have a true dural attachment. I know that Dr. Asher in his study did find that broad dural attachment was significantly correlated to local failure. So I think that right now, from the study that I presented, no, there was not a difference, but that I think is still to be determined.
So,
And Dr.
sorry.
Asher, I think, had a comment as well, perhaps.
Whatever it's worth, there has not been a strong correlation in the prospective or retrospective analyses to date. However, BN012 is one of the stratification criteria is posterior fossa versus supratentorial. So hopefully that will be a mechanism to at least look at those two compartments. There has been some suggestion in smaller studies that there's a higher risk in the of recurrence in the posterior fossa.
That's great. Dr. Weinberg, go ahead.
Sorry, the question was just with the patients who had the dural attachment, was the dura resected with that attachment, or was it left intact to be treated primarily with the radiation as the only modality of treatment for the residual tumor against the dura?
Jeff, the issue that we observed is it maybe could be stated more simply by suggesting that if there was a subtotal resection for any reason, and by the way, sometimes radiographically it appeared to be a GTR, but if the surgeon reported that there was significant adherence to, say, a draining vein near the midline, or if there was a dural extension beyond what appeared to be that immediate cavity, the risk of local recurrence was clearly higher. So most of the situations, Jeff, were simply a situation where it didn't seem to be feasible or safe to try and get everything that you could see even under the microscope because of risk of, again, a draining vein or eloquent cortex.
And I guess a follow-up question for Dr. Weinberg. So in case of gametile, if there is, because I think one of the picture you did show, it did have some dural attachment. So when you are placing gametile, are you just resecting that dura and still lining the cavity, or how do you take that into consideration?
So on that particular case, believe it or not, we actually had miscounted and we had an extra tile. So that dural involvement went beyond the craniotomy, and we tucked a tile under the dura going out. And that person is now 9 months after the surgery with no visible disease anywhere in the brain. So it worked. I can't say that we have regular occurrence of dura tracking like a meningioma, of tumor tracking along the dura like a meningioma. That we have an N of 1, and with that one, the patient has been successfully treated with the brachytherapy tile.
And the other question I had, maybe for Dr. Sakaria and Dr. Agarwal together, your data does show that breast mets do better compared to the others with SRS. And are these all patients on, say, a hormone modifying treatment? And Dr. Sakaria, would that have some kind of radiosensitizing effect for these people, why we're seeing what we're seeing?
Yeah, so we have not gone back and looked at these breast patients yet to see what systemic therapy agents they're on. But that's what I was alluding to when I mentioned in future directions that systemic therapy and the role and interactions between systemic therapy and radiation is going to be really important, especially in HER2 positive breast cancer. Incidence of brain metastases is increasing as the systemic control gets better and better. But at first, with the advent of Herceptin, systemic therapy control improved vastly, and that correlated with an increase in patients developing brain metastases. But Herceptin was not good at treating brain metastases. Well, now we have other systemic therapy agents that we can use that do cross the blood-brain barrier. And so combining those with the radiation, I absolutely think that that is contributing to better local control as well as in-brain control.
Yeah, I actually don't have much to add. I think that was a great answer. I do think that, the efficacy of TDM1 and some of the other antibody drug conjugates is interesting, but again, delivery is an issue. But at least some breast mets seem to respond. And then I think the triple negative cohort is pretty interesting. There's a subset of those that are more DNA repair deficient and maybe more inherently radiation sensitive. And then there's clearly others that are fairly resistant. I think that the holy grail will be identifying those patients we think are at highest risk for failure and enrolling those patients on novel therapies or novel therapy radiation combinations.
That's great. Dr. Weinberg had a comment.
Sorry, no, I think I forgot to take my hand down. Sorry.
Okay. I know we went a bit over time and cutting into the break, but I always feel like these discussions are worth their weight in gold for the collaborative comments across the faculty. So thank you all for joining us for this morning's session. We are going to take a brief break. All of the presenters are welcome to stay for the second half, especially seeing as we'll have some overlap with Dr. Agarwal's discussion and Dr. Asher's upcoming discussion. And then, of course, Dr. Weinberg's talk on gamma tile and Dr. Wardak's upcoming talk. We're looking forward to that. So let's take a brief
3 minutes.
3 to 5 minute coffee and bio break, and we'll reconvene in just a little bit and move on to the second half. Thank you.
I'd like to welcome everyone back and start with the second half of this morning. And our first speaker this morning, it's my pleasure to introduce Dr. Iroglu. I hope I'm saying this right. Dr. Iroglu is a medical oncologist in the Department of Oncology at Moffitt Cancer Center and is an assistant professor of oncologic sciences at University of Florida. Her clinical focus is on treating patients with advanced melanoma and other skin cancer, and also participating in clinical trials. Her research interests are translational clinical research in targeted therapy and combination immunotherapeutics for melanoma. And I hope I said your name correctly.
That was very close. Thank you.
So
I
how do
appreciate
you say it? Just so we can all hear it.
It's just a silent G, so Erol, Zainab Erol.
Errol. Okay.
Yeah, very close.
Well, welcome and thanks for
Thank
doing
you.
this.
Appreciate it. Okay, great. Thank you so much. So my name is Zainab Erolu. I'm a medical oncologist in the Department of Cutaneous Oncology at Moffitt Cancer Center in Tampa, Florida. I'm going to give a brief overview of some of the systemic therapy options, specifically for melanoma brain metastasis. These are my disclosures. So I think as some of you may be familiar, there's been a really significant advance in the systemic therapy options for metastatic melanoma within the past decade that have really led to improved survival. So it's been primarily two categories of treatments: the immunotherapy drugs, as listed here, with anti-PD-1 based immunotherapies, whether single agent or combinations, such as Nivo with Ipi, and actually earlier this year, Nivo with relatlimab, which is an anti-LAG-3. And then also in the category of targeted therapies for patients with BRAF mutant melanoma, which is about 45% or so of patients with melanoma. And there's currently 3 different FDA-approved BRAF MEK inhibitor combinations, which are pills available for patients with advanced melanoma. And you see those listed here: dabrafenib, trametinib, Encobini, Vemcobi. We do know that nearly half of patients with stage 4 melanoma do go on to develop brain metastasis. And historically, these patients have had very poor survival, typically, 6 months or less. And sorry, I seem to be having clicking issues. And generally, local regional therapy with surgery and radiation were basically the only options for these patients, and and potentially whole brain radiation therapy if those were not possible. And unfortunately, many of the early clinical trials in stage 4 melanoma that were looking at immunotherapy, targeted therapy, actually excluded patients with brain metastasis, or only allowed them if they had already treated or controlled brain mets. And so there was a lot of questions, with regards to would there be, issues with systemic therapy in melanoma brain mets, what the blood-brain barrier, would there be issues with, immune cells trafficking into the brain, lower concentrations of targeted therapies, etc. So finally, I'd say probably in the last 5 years or so, some of the newer clinical trials have finally looked specifically at systemic therapy in melanoma brain metastasis. And so one of the best, and I would say probably one of the most widely discussed trials is the Checkmate 204 trial. So this looked at a combination immunotherapy, ipilimumab with nivolumab, specifically in melanoma brain metastasis. Now, as a background, single agent immunotherapy, such as ipilimumab by itself, nivolumab or pembrolizumab on its own, were also looked at in melanoma brain mets, but there the intracranial response rates were only about, I would say, about 20% or so. So this trial actually looked at combination immunotherapy in melanoma. So the criteria for this study, there was a size limit. The patients had to have a minimum 0.5 centimeter brain met up to 3 centimeter, but no larger than 3 centimeters. And they did have to have one unradiated brain met to be eligible. They could have received prior stereotactic radiation for melanoma brain mets if finished more than 3 weeks prior, but they had to have at least one non-radiated brain met, at least 0.5 centimeter for eligibility. Could have had prior systemic therapy in certain settings, could have had prior targeted therapy. If they received prior immunotherapy, it had to have been one only in the adjuvant setting, so post-surgery, where we use immunotherapy a lot in stage 3 melanoma especially, but had to have been more than 6 months from the last immunotherapy given in that setting. And this study had 2 cohorts, and the largest by far is cohort A with asymptomatic melanoma brain mets, over 100 patients, good performance status, so patients not requiring any steroids for enrollment, whereas cohort B, which we'll get to after looking at cohort A, was specifically for patients with symptomatic brain metastases, so having neurologic symptoms or needing corticosteroids, 4 milligrams of dex or less a day or equivalent, and could have had performance status 0 to 2. The regimen given is standard used in melanoma with nivo-1, ipilimumab 3 mg per kg, 4 cycles followed by nivolumab monotherapy. And the primary endpoint was intracranial response. Of note, 9% of patients in cohort A did have prior radiation before enrollment, and 17% in the symptomatic cohort did have prior, again, stereotactic radiation before enrollment. So looking first at the asymptomatic melanoma brain met cohort, again, this was about 100 patients treated with ipi-nivo, again, first line in the metastatic setting. We can see here an intracranial response rate of about 54%. And of note, this is actually quite similar to what we see with ipi-nivo in metastatic melanoma in general, which is actually right about 55-56%. So there did not really seem to be any decrease in efficacy of ipi-nivo in asymptomatic melanoma brain mets as compared to other sites of metastasis of melanoma like lung, liver, bone, etc. And then the median time to response was 6 weeks, and this trial did have a 6-week brain MRI that was done after patients started on treatment. And then the study has now close to about 3 years of follow-up. So we can see here median PFS at 36 months, 3 years, about 54%. And again, the intracranial, extracranial response rates and progression-free survival rates were quite similar. And keeping in mind with melanoma brain mets, nearly, I would say all the patients also have extracranial mets as well that require treatment. For overall survival, we can see here at 3 years, 72% of patients still alive. After treatment with ipi-nivo and melanoma brain mets, again, definitely much better than the days of median survival of less than 6 months. So 72% alive at 3 years. You can see the curve here. We'll need longer follow-up, but median PFS and OS actually have not yet been reached for this study in the asymptomatic cohort. I emphasize that because of the data in the symptomatic brain mets, which again was the group of 18 patients, same trial, same regimen, except those patients had either neurologic symptoms from the brain mets, and again, many were on corticosteroids. Up to 4 milligrams of dex was permitted prior to enrollment. Far worse outcomes for these patients. We can see instead of 54%, 22% intracranial response rate, so far worse than what we see with ipi-nivo and melanoma metastasis. Median intracranial PFS of only 1.2 months with ipi-nivo in symptomatic melanoma brain mets. And again, overall survival quite poor at 8.7 months. sure I can keep advancing my slides. And sorry, and incidentally, the toxicity profile with ipi/nivo, there was not any new toxicity seen specifically in melanoma brain mets compared to the toxicity profile of ipi/nivo in metastatic melanoma in general. Another large, important clinical trial, also looking at combination immunotherapy. This was the ABC trial. So this was a group of sites from Australia. Similar criteria for enrollment, except they actually allowed just up to 4 centimeters in terms of the largest brain mets, did not allow any prior systemic therapy. And this study had 3 cohorts. The largest is very similar to the Checkmate 204 we just discussed, giving ipi/nivo standard dosing. They also looked at nivolumab by itself, so single agent PD-1, and then cohort C was their symptomatic brain met cohort, could have had leptomeningeal disease, treated with nivo alone, and intracranial response, again, the primary endpoint. With this trial, we can see in cohort A, asymptomatic brain mets with ipi/nivo. Data is quite similar to Checkmate 204, except now we actually have up to 5 years of survival, intracranial response 51%, and we can see nearly half the patients without progression at now 5 years of follow-up for cohort A. Not surprisingly, cohort C, symptomatic patients, far worse outcomes here, a sharp drop in progression-free survival right at the beginning with 6%. And also with overall survival, again, nearly half the patients treated with ipi/nivo, asymptomatic brain mets, alive and well at 5 years. Symptomatic brain mets doing much worse, only 13% alive. The investigators did note these long-term survivors did seem to have a lower burden of extracranial disease, normal LDH, and better performance status compared to the rest of the patients. This study did actually report the subsequent treatment that the patients received if they did have intracranial progression of their melanoma, and reporting this in the 3 cohorts. And not surprisingly, we can see that for many of these patients, if they did have progression of brain mets on immunotherapy, actually many went on to receive local therapy, about a third with ipi/nivo and nearly 2/3 with the nivo alone, stereotactic or whole brain radiation, some of them receiving surgery, and then 2/3 receiving a different type of systemic therapy as well. And again, patients may have had, multiple regimens here, radiation, systemic therapy, many of them receiving BRAF targeted therapy if they had not received that before. Of note, the investigators did report that a few of the patients, 1 of 3 while on study and 2 out of 10 post-study, did actually have radiation necrosis. So these were patients who received radiation after progression of brain mets on immunotherapy. So switching gears to targeted therapy. So we've been talking about immunotherapy until now. So looking at targeted therapy. So again, nearly half of patients with melanoma will have a BRAF mutation, which would make them eligible for BRAF and MEK inhibitors. So this was the COMBI-AMBI study looking at dabrafenib and trametinib, a BRAF-MEK inhibitor combination specifically in melanoma brain mets. The study is a little bit confusing in that there's multiple cohorts, but the largest, as you can see, is 76 patients. Without any prior, this did not permit any prior radiation in this cohort, and asymptomatic melanoma brain mets, although they did have another cohort of 17 patients where they did allow symptomatic brain mets as well, and could have had prior radiation or surgery in a few of these cohorts. So what we see here is looking at intracranial response of melanoma brain mets. The response rate's about 58%, a little bit lower in the less common BRAF mutations. But what's interesting here is that this intracranial response rate, although it's it's impressive and similar to what we see with ipi/nivo, is actually lower than the response rate we see in melanoma metastasis in general, where it's closer to about 70-75% with stage 4 melanoma treated with dabrafenib trametinib, and we do see a decrease in intracranial response with BRAF/MEK inhibitors in the brain. And then the median progression-free survival about 5.6 months. Interestingly, not really any major decrease in symptomatic brain mets, kind of similar with symptomatic versus asymptomatic brain mets with targeted therapy. But again, we see about 1 year median PFS when these drugs are given in melanoma metastasis, patients with lung, liver, etc. So definitely a lower median PFS with targeted therapy in melanoma brain mets versus what we see with extracranial metastasis. And these are just the survival curves for progression-free survival. So long-term, I would basically emphasize that for asymptomatic melanoma brain mets, the data is definitely better for long-term survival for PFS and OS with ipi/nivo immunotherapy than it is with BRAF targeted therapy. Again, that's only for asymptomatic brain mets. So of course, an obvious question here is, why not combine these? Why not look at a combination of immunotherapy and targeted therapy in patients specifically with BRAF mutant melanoma brain mets? And we actually do have some data from a clinical trial that was just reported at ASCO earlier this year. So this is the TriCatel study from Europe that looked at an anti-PD-L1, it's atezolizumab with a BRAF/MEK inhibitor combination, VEMCOBI, in this case, BRAF mutant melanoma brain mets. There was no upper size limit for this study. They had to have at least 0.5 centimeters to enroll, but no upper size limit there. They did not allow any prior systemic therapy here. They could have had prior radiation or surgery, and they did have symptomatic brain met patients as well, and those they could have had up to 8 milligrams a day of dex or equivalent for enrollment. And basically, the regimen is a little bit complicated, but it basically starts with 28 days of VEMCOBI, and then the atezolizumab is added, and then after cycle 2, all 3 drugs are given concurrently. And here the data with this triplet regimen, again, this was a single arm study. Looking at this, we can see here in all patients, they had 65 patients. This was a mix of symptomatic, asymptomatic. The intracranial response, 46%, median PFS, 5.8, which is not that impressive, given the data with ipi/nivo in the asymptomatic mets having much improved median PFS. But if we look at symptomatic brain mets only, and this was 24 patients total. Interestingly, the investigators saw an intracranial response rate of 58% in these 24 patients, with a median PFS of 7.2 months. And keep in mind, with ipi/nivo in symptomatic melanoma brain mets, that number is only 1.2. So 7.2 in this study of a triplet regimen with immunotherapy and targeted therapy in melanoma brain mets, specifically in symptomatic patients. Investigators did note for the symptomatic patients, about half of them who had been on steroids at baseline were able to taper them down or discontinue them in the first month. Now, of course, one concern with triplet regimens is the increased toxicity. We can see there's definitely an increased rate of grade 3-4 toxicities, which is kind of what's expected with VEMCOBI and atezolizumab in metastatic melanoma. So one question is, of course, how does a triplet regimen actually directly compare to ipi/nivo? So that is an ongoing trial we have, the SWOG S2000 study, which I believe is actually also open at University of Wisconsin as well. So in this study, patients with BRAF mutant melanoma brain mets are randomized 1-to-1 to either a triplet regimen of this time encorafenib and binimetinib, BRAF MEK inhibitors with nivo, versus ipi-nivo. And this study does allow symptomatic brain metastasis up to 8 milligrams of dex a day, does allow patients, to have gotten prior radiation surgery as long as there's an untreated brain met that remains, and allows prior neoadjuvant and adjuvant systemic therapy. And then another ongoing clinical trial that everyone's interested in seeing results is the ABC-X study. So this is kind of a follow-up to the prior ABC study I discussed earlier with ipi-nivo. So this is again from the Australia group, where they're looking at how radiation combined with immunotherapy may impact outcomes. So they're looking at only asymptomatic brain mets here, up to 4 centimeters for brain mets, and patients are randomized to ipi-nivo versus ipi-nivo with concurrent stereotactic radiation, and then going on to standard nivolumab immunotherapy. So I don't think there's been any data published yet from this study. I believe this is ongoing, and the SWOG study is ongoing as well. And of course, there's other ongoing clinical trials in brain mets as well, looking at other targeted therapy agents. Another interesting one with looking at bevacizumab with pembrolizumab in melanoma brain mets. So I would say in terms of, kind of where we are with systemic therapy in melanoma brain mets, so if we look for any guidelines in terms of treatment decision making, and again, I would emphasize the importance of multidisciplinary approaches for looking at how to treat melanoma brain mets. But basically the guidelines published, I believe just last year from ASCO, SNO, and ASTRO, with regards to melanoma, basically comments that ipi-nivo or BRAF MEK inhibitor therapy may be offered to patients with asymptomatic brain mets, and that if these drugs are used, local therapy could potentially be delayed unless there's evidence of intracranial progression. And again, I would keep in mind that all of these trials did do a brain MRI within 6 weeks of patients starting on treatment. I was looking to see if there's any published guidelines or paradigms. I would say, before getting to that, just factors to consider for treatment of melanoma brain mets: size, location, extent of symptoms of the mets, extracranial disease, which again, nearly all patients will have, the patient status, comorbidities, and what systemic therapies have they already received, and BRAF status, all important to consider. This was one flow diagram I was able to find online that kind of tries to put all this together, and it's still a little bit convoluted, but essentially highlighting that for asymptomatic brain mets, it says 1 centimeter here, but actually these trials, like with ipi-nivo, allowed up to 3 centimeters, that upfront systemic therapy could be considered. Although again, stereotactic radiation or surgery, certainly very reasonable options as well. Again, highlighting importance of multidisciplinary discussion of these patients. And then the type of systemic therapy does depend on what the patient's already received, but in most cases would be ipilimumab with nivolumab, again for asymptomatic brain mets, given the good long-term follow-up and survival with these patients. A few exceptions would be if the patient progressed while on immunotherapy with a new brain met. In that case, the BRAF status becomes important because those patients may benefit from targeted therapy. And of course, many of them would benefit from stereotactic radiation or surgery as well if they are developing brain mets while on immunotherapy. And again, if there's subsequent progression in a patient who receives upfront ipi-nivo for a melanoma brain met, in many instances, radiation or surgery become very important treatment options. And then in terms of systemic therapy for those patients, looking at, again, clinical trials and alternative immunotherapy drugs. For symptomatic brain mets, again, I would emphasize the importance of trials, but many of these patients will need stereotactic radiation or surgery up front, and then many of them afterwards will still need to go on to receive systemic therapy because many will have extracranial mets as well that will require treatment. So in summary, and a few questions, systemic therapy for melanoma brain mets can lead to durable responses and long-term survival in select patients with melanoma brain mets. I would say mostly those with asymptomatic metastasis. Certainly the role of radiation is very important, and obviously questions about, how to best sequence radiation and immunotherapy. Do we need to worry about radiation necrosis? Again, some ongoing trials that are exploring this question of combining radiation and immunotherapy for melanoma brain mets. I would say ultimately, many of the patients will require multimodality therapy, even if they start with the radiation or surgery, they will need systemic therapy afterwards, or vice versa. If start with systemic therapy, and if they go on to have progression in the brain, will require radiation. And again, multi-D review of these patients with team including neurosurgery, radiation oncologist, medical oncologist, very important. I still think many questions we don't have answers to yet. Which patients should you defer local regional therapy and start with systemic therapy, and vice versa? Optimal sequencing, which combinations should be developed further in trials. And I would highlight the importance of enrollment into trials for brain metastasis. And I would say it would be great to include patients with brain mets on earlier phases of drug development. Unfortunately, many of the studies I discussed with immunotherapy, targeted therapy, all were started, after there was already FDA approval of these drugs in stage 4 melanoma, as these patients were excluded from those earlier trials. And also want to highlight the importance of course, translational studies as well, looking at the biology of melanoma brain mets, including prevention of melanoma brain metastasis. And that is all I have for my slides. Thank you.
Thank you so much. That was just an amazing talk. I appreciate that. I know I do have some questions, but we're going to hold those until the end if that's okay with you. But thank you so much. I thought that was just wonderful. So we'll move on to our next speaker, Dr. Stephen Yip. Dr. Yip, thanks so much for joining us virtually. We appreciate you. And I'm very pleased to announce Dr. Yip's presence with us today. He's a board-certified neuropathologist with postdoc training in molecular experimental neuro-oncology and fellowship training in molecular genetic pathology. Dr. Yip has done some very important work with significant contributions to the world of neuropath, and having been deeply involved in the 2016 reclassification of central nervous system tumors from the World Health Organization. And today he's going to share his knowledge with us on the use of molecular and targeted therapies specific to brain metastases. So Dr. Yip, thanks so much. The stage is yours.
Thank you. I'm just going to share my screen here.
Yep, please. That'd be great.
So again, thanks very much for inviting me to give this talk. I'm really going to talk about brain mets and molecular targeted therapy from the neuropathology and molecular pathology point of view, and maybe go back to basic a bit on sort of the incidence and prevalence of the different types of brain met we see in our clinical practice, and how we can incorporate molecular diagnostics, identifying potential targets into our overall treatment regimen. These are my disclosures. So again, the objectives are again, back to basic a bit, surveying the landscape of metastatic tumors in the CNS and identifying various molecular targets in tumors. And I think these pretty much just represent what they are outside CNS as well. And I'll give 4 examples of molecular targets in CNS metastatic lesions. When I first came back to Vancouver for my fellowship, I did a survey of the type of brain met that we see in our neurosurgery service. This is a really rough survey, but as you can see here, CNS mets are represented by all sorts of primary tumors. So oftentimes they represent the prevalence of these tumors in the general population. We are seeing more effective systemic therapy for patients outside of CNS. Hence, patients are living longer and they have a much better chance of developing CNS mets. So, but you can see here that we see a lot of lung, breast, colorectal, but also at the same time, we see fairly unusual or somewhat rare tumor as well. But if you think about it, these patients are living longer, so there's a much better chance for them to actually develop seeding of the brain. So HCC, endometrial cancer, various gynecological cancer, even mesothelioma we've seen in the brain. Obviously, when I say that the prevalence of CNS mets represent or mirror the prevalence of these tumors in overall, I think that there are also exceptions as well. For example, prostate cancer is fairly common. It's actually extremely common in male, but we don't really see representation of this prevalence in the CNS. So I think CNS mets is a combination of the prevalence of cancer in the systemic sense, but also there's also intrinsic biological activity of the tumor that dictates setting up shop in the brain or the leptomeninges. This is a microscopic picture of a metastatic adenocarcinoma to the brain. And I think the key feature for CNS met is that as opposed to primary intraaxial brain tumor, metastatic tumor often have a well-defined demarcated boundary with the adjacent brain. And as you can see here, you can almost, with a pen, draw a line between the metastatic tumor on the right side versus the reactive brain on the left side of the screen. There's really no degree of infiltration compared to primary brain tumors such as astrocytoma or oligodendroglioma. In the brain on the left side, you do appreciate some degree of reactive changes, astrogliosis, but also you can actually see lymphocytes around blood vessels. And I want to really sort of direct your attention to the vasculature of the brain in tumors, but this is actually a big factor, not only in metastatic tumor, but also in primary brain tumor. The blood-brain barrier has been a major obstacle to the delivery of systemic therapy for both types of tumors. And I think improved understanding of the blood-brain barrier will significantly help us to deliver more effective systemic therapy and also targeted therapy for CNS mets. There have been a lot of work done on understanding the underlying cell biological as well as molecular features of the blood-brain barrier. We all were taught from medical school that the blood-brain barrier is mediated by tight junction, basement membrane, but also controlled by astrocytic end feet. Blood-brain barrier can strongly be compromised in various pathologic conditions or in neovascularization, for example, from that we often see in GBM, but also in various type of metastatic tumor as well. and also interventions such as ionizing radiation. And now we actually deliberately use ultrasound to transiently disrupt the blood-brain barrier to mediate improved delivery of therapeutic agents to the brain. So certainly there are ways to modulate blood-brain barrier to improve delivery. But in vast majority of patients, the blood-brain barrier has been an obstacle for the effective delivery of systemic therapy. Then that would also include targeted therapeutics. With respect to the type of molecular alteration that we see in brain mets, as I've shown before in my pie chart, CNS mets, patients living longer, then we're just seeing a fairly comprehensive representation of systemic tumors in the CNS. And obviously, these tumors will also represent the type of unique genomic alteration that they carry. So I think this becomes an opportunity as well as a challenge as well, because like if we know that a particular targeted therapeutic works on a tumor outside the brain, most likely it will work when that tumor goes to the brain as well, or the leptomeninges. The challenge is pharmacokinetics and pharmacodynamics, and how do we get that agent through the blood-brain barrier? These are just some examples of targeted therapeutics that are being considered in brain mets. And in the previous lecture, there's already been a very extensive survey of the melanoma landscape. So this list basically describes a lot of small molecule compounds that were being considered or are actually in trial for various brain mets. And I think these are fairly obvious targets. Melanoma, obviously, BRAF driven in vast majority of cases, BRAF MEK inhibitor. Non-small cell lung cancer, obviously, there are very effective tyrosine kinase inhibitors of various generations, first, second, and third, and now even the more newer therapeutics such as lazertinib are also being considered for CNS mets from patients with non-small cell lung carcinoma. And also the use of kinase inhibitor in breast carcinoma. A lot of these targeted therapeutics are often used in combination with other targeted therapy or with more traditional chemotherapy. So I just want to give some examples of 4 examples of these targeted therapeutics for brain mets. It's going to be more focused on the molecular biology and molecular diagnostics of identifying these alterations and how we can actually best deploy this information when treating patients. First example is osimertinib for targeting EGFR driven non-small cell lung cancer. I think this has been one of the EGFR alteration has been one of the poster child of targeted molecular therapeutics, and has been a great success for the past 20-25 years. Since we know that a large proportion of non-smoking associated adenocarcinoma of the lung have EGFR alteration, and even a small proportion of smoking related also have EGFR alteration as well. A lot of these alterations are what we call canonical and hotspot mutation. That is, they are found in functionally very important part of the gene that regulate the protein function. So some good example would be L858R or exon 19 deletion that leads to tremendous overactivation of the EGFR protein. The ability to drive cancer behavior also becomes an Achilles heel of the cancer. However, to identify these patients, we do have to do routine molecular profiling and sequencing of these cases to identify whether they actually have the mutation or not. So this really becomes a big issue, is that we really need to be doing this in a reflexive manner on all patients. And my opinion is that we should be doing this agnostic of stage as well. So if we have an early stage lobectomy specimen, we should just do it if we can find out that the patient indeed has a non-small cell lung cancer and is adenocarcinoma. And even if we do not have the ability to give drug to this particular patient, having this information will give us a head start if the patient develop later stage disease or metastatic deposit or to the brain, in which they really do need this information quickly. What about the stability of these driver alteration? What is the distribution of, example, EGFR or ALK or ROS1 alteration age versus metastatic disease? I think the data here is somewhat fuzzy, and I think it might be a bit biased in some way, but I think overall there is a fairly good concordance between the prevalence of driver canonical or root mutation found in both early and late stage. And I think that also makes sense as well. If you think about a KRAS mutation, it's extremely oncogenic, similar to EGFR, ALK translocation, ROS, RET. And if you find it in an early stage, most likely the same alteration will be driving late stage behavior. Late stage disease might gain additional alteration that gives them more aggressive behavior. And also keep in mind that a patient that had been treated with a previous round of targeted therapy might develop novel alteration that allows them to escape from the first line targeted therapeutics. And some of these examples would be EGFR T790M, or in the case of osimertinib, I think C797S, or even MET amplification are some of the known escape mechanism for patients. So I believe in routine molecular testing, agnostic of stage, but also we should also have the flexibility of retesting patients, especially if their disease changed behavior, particularly after a round of targeted therapeutics. This is an oncoprint of stage 3B and 4 non-small cell lung cancer at BC Cancer, where I practice. So we have a massive practice. We do about 1,800. We do about 1,300 cases a year in terms of NGS profiling for non-small cell lung cancer, and that's only about 70% of all cases that are 3B to 4. So what you see here is that vast majority of our cases show KRAS mutation, of which about 40% are G12C. And that is significant because I'm going to talk about this later, of the use of the introduction of sotorasib or adagrasib for G12C alter cancer. The next most prevalent alteration that we see in Vancouver is EGFR. It's actually 22%, which is a bit higher than what most center has reported. And I think really for the reason that Metro Vancouver has a high percentage of Asian, and a lot of them are non-smokers. So I think EGFR alter lung cancer is actually well represented in our cosmopolitan cohort. When we actually look at EGFR prevalence in the outside area in Prince George, Kelowna, the percentage is a bit lower compared to Metro Vancouver. Other things that we see in Vancouver in our sequencing cohort, obviously ALK translocation, we see rare ROS, we see extremely rare NTRK alteration as well. But I think what we found here is well represented and also correlate with the TCGA data set. But I think what you can see here is that understanding the molecular driver of cancer at stage 3B or even earlier will give us a leg up on treating these patients with the appropriate therapeutics. So with respect to lung met to the brain, I mean, it can appear as in many forms as a solitary lesion, it could be multiple lesion, and it could be leptomeningeal spread or even spread to the pineal gland into the choroid plexus as well. Some of these are surgically amenable to surgery or radiotherapy, and some, such as leptomeningeal spread, can be quite debilitating, and the ability to actually get tissue biopsy could be quite challenging. So that really becomes a dilemma. For example, I think I'll show you this here. This is no longer the case in Vancouver once we after we switched from the use of erlotinib, gefitinib to osimertinib as a first-line treatment for lung cancer. But about 2 years ago, when we still have patients on erlotinib with the disease well controlled, if they present with leptomeningeal disease, then we would need to know, do they actually have evolved a T790M mutation? Again, because it's so challenging to get leptomeningeal biopsy, we really have to resort to alternative method to identify these sensitizing alterations. So one of which would be using liquid biopsy on either CSF or plasma for these patients. Having said that, now this has become moot because osimertinib is our go-to first-line targeted therapeutics for all non-small cell lung cancer with EGFR alteration. But then we have to anticipate the next step as well. So patient whose disease is well controlled by OSI might down the road develop resistance, and that could be mediated by, as I said before, C797S or MET amplification, or maybe HER2 amplification. So again, the ability to anticipate these changes and to have the appropriate assay to cover these changes is needed. And also in challenging cases, then the ability to actually perform these assays in non-invasive, so for example, liquid biopsy, needs to be considered. My next example is the advance of using Enhertu in breast cancer. So I think this has become a really, really good news story, but it's actually become a huge challenge for the lab because now we're really scrambling to define low HER2 amplified breast cancer and a consistent way of defining these. But basically, this is a great story for patients with breast cancer. And in fact, I think there are evidence that Enhertu is actually showing efficacy in patients with brain mets. And as shown in this paper here, there is objective response of brain mets in a patient to Enhertu. So again, success of a chemotherapeutic agent or target therapeutics in the clinical realm often put pressure on the lab to develop the appropriate assay to address these questions. Targeting of KRAS G12C, I think this is a really good story because G12C alteration, as I've shown you, is very well represented in lung cancer. It's actually it's probably the group that actually best represents G12C compared to colorectal, which has a much lower percentage of G12C alteration. And I think others such as pancreatic adenocarcinoma even have a much lower representation. But you can imagine that you can actually tackle the pie in the molecular alter landscape of lung cancer. And I think having these two drugs really give us the tool to really manage lung cancer mets. So again, G protein overactivation is a really common method for tumor to gain a growth independence and immortality. And G12C, as I mentioned, is fairly well represented in non-small cell lung cancer. Sotorasib has been shown to be very effective against G12C alteration, and also in CNS mets as well. So because it's a small molecule compound, it actually can cross through the blood-brain barrier fairly well. Another drug, adagrasib, is an irreversible binder of G12C, KRAS, and also has a longer half-life as well. So I think these two drugs are looks very promising for the treatment of G12C alter cancer. So again, in a really tumor agnostic manner, but vast majority of this is really represented by non-small cell lung cancer. And adagrasib or maybe even additional G12C inhibitor will definitely change the landscape of how we manage these patients. So I think in a way, I've sort of gone through this example in a tumor-specific manner to example which are more tumor agnostic. So from Aussie to Enhertu to G12C inhibitor. And my last example is truly tumor agnostic. So that's really the targeting of NTRK alteration with larotrectinib or entrectinib. Unfortunately, these alterations are what we call common alteration in uncommon tumor. So one good example is infantile fibrosarcoma. It's actually found fairly well represented in this tumor. Unfortunately, it is a really rare tumor, and we might see about 5 or 6 cases a year at Children's Hospital. But it is also an uncommon alteration in common tumor. So finding it in common tumors such as colorectal cancer or non-small cell lung cancer, it is certainly possible, but they are often found in 1% or even less of all cases. So the challenge really becomes having an assay that will give us the ability to detect not only common alterations such as EGFR out translocation, but also the ability to identify these really rare patients with NTRK alteration. And I think for the lab, one would rather do this in a single assay using a multi-gene NGS panel rather than having 5 different assays looking at 5 different alterations. So I think it really becomes an economic question. This is actually a really, really nice paper showing the prevalence of NTRK alteration in all cancer types. So it's 0.22%, not very common. But we do have a sense of relative prevalence of NTRK alteration. As I said before, infantile fibrosarcoma is fairly well represented for NTRK alteration. It's usually ETD fuse. But other tumor types such as mass, salivary cancer, do show much higher prevalence of NTRK alteration than more common types cancer, such as non-small cell lung or colorectal cancer. But I think given the availability of such an effective agent, I think it's really I think it really put pressure upon the lab to actually address the identification of this alteration. So these are some additional data representing the prevalence of NTRK alteration in different tumor types, and also the additional challenge for the lab is NTRK alteration is extremely promiscuous, and it could involve NTRK 1, 2, or 3, and the binding partners can be quite variable as well, and some of which could be specific to a tumor type. So an assay has to be broad enough that it would capture all these alterations, maybe not 100% of it, but hopefully at least 98 to 99% of them. But it is certainly challenging to do this in a lab in which we have to run assay for all cancer types. Having said this, it's been shown that NTRK inhibition, agnostic of tumor types, as long as they show NTRK fusion, is extremely efficacious. And we know that it works in the brain, and I think one of the 2 NTRK inhibitor has better CNS penetration. And some primary brain tumor also exhibit NTRK fusion as well. And we know that NTRK inhibitor actually work very well in that regard. So in summary, I've sort of given a description of the representation of CNS Mets at least in the Vancouver cohort, that we actually see a full spectrum of systemic cancers, from the very common to the rare and the exotic. But because patients are living longer due to more effective systemic therapy, we're definitely seeing a very well represented spectrum of these cancer. And keep in mind that CNS mets can be represented by solitary multiple cannonball lesion, but also leptomeningeal disease as well. And these often present very unique challenges for pathology, but definitely for treatment as well. And I think it was really important for us to identify molecular targets in CNS mets, either in early stage when we actually have availability of tissue for testing, or if we actually don't have the ability for good tissue, have the ability to have a liquid biopsy to these targets. So that's it for my talk. Thank you.
Thank you so much, Dr. Yep. That was just a fascinating talk. I sit back in awe sometimes about how complex these metastases have become, especially in an era of molecular testing. Dr. Urlu has to leave after this talk right now, and I know there was one question that had come up and wanted to see if you were okay answering that. One question was with specific regard to like a cost analysis. You know, we talk about kind of delaying treatment with either focused radiation versus surgery in order to let, you know, ipi-nivo work over a number of weeks. Has anyone ever looked at the expense related to delaying those local therapies and in prescribing these super expensive targeted immunotherapies? Like, has that ever been evaluated?
You bring up a great point. Not to my knowledge, in the context of some of these large trials that I mentioned with ipi-nivo and BRAF MEK inhibitors and melanoma brain mets, I don't recall any of them, at least not published, any data on cost analyses. You're correct that they're quite expensive. I think in those rare instances where patients, you know, came internationally, you know, without US-based health insurance and asked, say, I'll just pay for it up front, and they're always shocked at just the cost of it, sometimes tens of thousands of dollars, you know, per infusion with immunotherapy drugs and targeted therapy drugs, quite expensive as well. I guess what I would say is for most patients, with melanoma, they end up needing the systemic therapy anyway. So it's not that, you know, for a very large majority, that if you do upfront, you know, local regional therapy, radiation, or surgery, that you're done, and that melanoma patient then does not, you know, need to get immunotherapy or targeted therapy. There's a few rare, you know, exceptions to that, but almost always these patients also have extracranial disease that will still require immunotherapy or targeted therapy. So cost-wise, you usually still are going to need to, you know, use the drugs and, you know, the cost that comes with it. So generally, it becomes more of a timing, right? Do you start it up front and delay the local regional versus do that? But even if you do upfront local regional, almost always the patient is still going to get systemic therapy if they haven't already received it, if that makes sense. I don't know if that answers your question.
It does, yeah, 100%. Thank you so much. I appreciate that.
But just to follow
Yeah,
up
please.
question on that, like how do you navigate someone who's symptomatic waiting for 6 weeks for things to work? Like how do you actually logistically you know, navigate that? I would think someone symptomatic, they would want surgical intervention up front and not wait 6 weeks to wait for these targeted therapies to work.
That's a good question. I would say for patients not on any clinical trials, I think the patients with symptomatic brain mets almost always do get radiation or surgery, and sometimes both. And again, and oftentimes they may actually be seen by, neurosurgeons or radiation oncologists even, before they may see a medical oncologist. So I would say, but I do think it's important to bring in the medical oncologist early on as well, and to really have that multidisciplinary discussion of, okay, what do we, utilizing tumor boards, et cetera, what's really the best upfront treatment? Is it surgery, radiation? Where does systemic therapy fit in? I think that, you're right that for symptomatic mets, oftentimes the local regional therapies are still important. But with clinical trials, they do permit, so for example, this discussion of, okay, so let's say there's one particularly symptomatic brain met in a high risk location that needs surgery or radiation. Okay, do that, but then right afterwards, then start the patient on systemic therapy, right? So there's not always a big delay. Typically, in our experience, within about a week or so, we are able to start when they come to clinic, when we're first aware of the patient, able to start them on systemic therapy. But typically, we do have the discussion, with the radiation oncologists, neurosurgeons. Okay, is it okay to wait, right? If a patient has symptomatic brain mets, and see if our systemic therapy is going to work. Because you're right, it's the first follow-up is that 6-week brain MRI after we start. So I would say probably for symptomatic brain mets, if they're going to do upfront systemic therapy, it's probably best in the context of a clinical trial. And again, really important for the multidisciplinary discussion, as many of them may need these things all together, surgery and then the systemic therapy right afterwards.
Great. Thank you. Yeah, we appreciate your time. Thanks so much. We know you have to take off, but we appreciate you being a part of this discussion, and thank you for spending some extra time answering those questions for us that came through.
Oh, it says there's a question from me in the
here we go at the Q&A.
Yeah, thank you. Thank you, Dr. Aroglu. It was a great talk. The one question that I had is if there was any correlation between the patients on higher doses of steroids, like more than 4 milligrams daily, and decreased PFS and overall survival.
So the Checkmate 204 study, which had that cohort of symptomatic brain mets of 18 patients, actually only allowed up to 4 milligrams dexamethasone, or neurologic symptoms. And I don't think they reported separately from those 18 patients, like the data on the different steroid doses, and if it was higher, did the patient do worse? I think all of them did so poorly with those 18 patients, and the intracranial progression-free survival, like 1.2 months. So basically, the first time you get the brain MRI, with progression, I don't think they reported that. The Tricotel study, that's the one with the single-arm triplet regimen with the BRAF MEK inhibitor and the immunotherapy for symptomatic, and had also a symptomatic brain met cohort of 24 patients, allowed up to 8 milligrams dexamethasone. That trial was published in Lancet, and when there's details they give on which patient fit the criteria of symptomatic brain mets and for what reason, but I don't think they broke it down. And it's actually a good point, and maybe they should. I don't think they broke it down though from the dose of the dex received, like more than 4 or less than 4. Was there a difference in terms of PFS and OS for those patients? So, but I do think that's a good point. In our study, which is the SWOG S2000 with the Incobininiva versus Ipi-Nivo, we also allow up to 8 milligrams of dex. So I do think, once we get to analyzing the data from those patients, we're still enrolling. I think that's definitely a great point and something we will look at for our patients.
Thank you. Thanks, Dr. Santos, as well, for asking that question. That's great. We'd like to move on to Dr. Asher's talk. It's my pleasure to introduce Dr. Asher. He's a professor of neurosurgery at Atrium Health. He's a nationally recognized leader in his discipline, having held numerous senior leadership positions in neurosurgery, including President of the Congress of Neurological Surgeons, Vice Chairman of the American Board of Neurologic Surgery, Chairman of the Brain Committee of the American College of Surgeons Oncology Group, and also a member of the American Association of Neurologic Surgeons. Very excited to hear his talk on preoperative gamma knife stereotactic radiosurgery and brain metastases as an adjunct to Dr. Agarwal's talk. And for having been a site that just recently activated BN012, we're excited to hear a lot about that. So Dr. Asher, I'm glad we worked out all the technical issues. Welcome. And thank you so much for agreeing to be part of this talk today.
It's a real pleasure, and I do apologize for, I think most of those technical issues were actually on my end. I know that Stuart Burry and Sean Prabhu were also asked to present, and hopefully I don't prove to be a poor substitute for my colleagues who just are not only close friends, but we've been involved in these endeavors with for almost 20 years now. Scott Solz has been mentioned. Scott is actually one of our co-investigators on the NIH protocol that we'll be talking about in a few minutes. And I think that it's either irony, coincidence, or whatever, that this is what I got called in to see this morning in this patient. You can't see the uppercuts, but newly diagnosed lung CA with a tremendous posterior pulsing mass effect and hydrocephalus from these cousin metastases in the right cerebellar hemisphere. And so we do a lot of this disease. This is an example of very symptomatic met. Certainly this patient was not going to be able to wait for the results of systemic therapies. But today our focus is going to be on surgical therapies. Folks, I'm going to provide a little context. Dr. Agarwal gave a really fantastic conversation, rather a presentation, so it'll allow me to summarize some of these slides. But I will provide maybe a little bit more background as to why we got into this in the first place and why we think it is potentially significant. I don't have to remind everybody here about the significant societal relevance of cerebral metastases. And interestingly, and originally I had been doing a lot of clinical research on primary malignancies. We pivoted to cerebral metastases research several years ago for three main reasons. One, we found that there was a really fundamental lack of consensus related to treatment paradigms in what we would consider to be standard care situations. We therefore felt that there was a high potential for clinical trials focused on very basic elements of care, straightforward questions to have some impact, if nothing else, in reducing care variability. We have tremendous clinical volumes by a variety of measures, probably the largest brain metastases volumes in the Southeast. And then, as you saw on the last slide, it's an order of magnitude potential to increase the investigational practical footprint of your work with brain metastases. And we just know how often brain mets will confound otherwise successful systemic therapies. This is our team. Again, I cannot emphasize enough how much of a team effort this is. I would say in particular between radiation oncology and neurosurgery, there has been not just an easy relationship over the years, but an amazingly synergistic relationship. I love the fact that this particular seminar is being co-sponsored by departments of neurosurgery and radiation oncology. These are essential relationships. We've been devoted to building on these relationships on a regional and national level. And again, I just we have experienced and our patients have experienced great benefit as a result of that cultural dynamic. When we look back at our early experience when we were just starting to get into it, so it was mentioned that I had been the chair of ACOSOG's brain group. When they did have a brain group, they moved on to other things. But we were investigating various avenues of investigation, and whole brain radiation therapy is still a widely used method for primary and adjuvant treatment of brain metastases. Now, I want to mention, I am not making a broad statement about whole brain radiation therapy. I understand there's hippocampal sparing and medicines we're using to decrease neurocognitive side effects of whole brain. I'm mostly going to be referring to surgical lesions here. However, I will say that whole brain was far more prevalent in that time period. In particular, combination therapies with whole brain, SRS plus whole brain, it really gained in popularity. It was a fairly common treatment paradigm. And why was this thought to be a benefit? This combination, that is to say, SRS added to whole brain radiation therapy, seemed to improve local control of METs, decreased the development of new brain metastases, and also, again, this was another situation where nurses and radiation oncologists were finding ways to work together. But the one thing that came up in numerous studies, particularly coming out of UCSF, was that no improvement in survival has been noted with the addition of whole brain radiation therapy in these situations. And so the treatment controversy at the time, and it was for several years after this, was should adjuvant whole brain be administered with SRS to improve intracranial control? I won't get into all, Dr. McElroy mentioned some of this. By 2010, 3 single institution RCTs had looked at this combination of therapies for oligometastases, and there really were conflicting conclusions regarding the impact of whole brain. I should mention that our original trial through RACOSOG was approved by CTEP in the mid-2000s. It was closed down because CTEP at that time would not recognize a quality of life and neurocognitive endpoint. Think of that. As recent as 2006, 2007, they would only accept a survival endpoint. We told them that survival was not going to be an issue. We were forced into a situation where we had almost a 500 patient accrual goal. And although we were accruing fairly vigorously, we were falling behind on it. Flash forward, NCCTG picked up the study. I became the co-investigator with Paul Brown on what became known as N0574. We basically were randomizing patients with oligometastases to SRS versus SRS plus whole brain. And we used really for the first time fairly sophisticated and standardized neurocognitive quality of life batteries. And I think this is what differentiated this trial from the ones that had preceded it. And long story short, we published our results in JAMA in 2016. We showed, I think, fairly definitively there was a decline in cognitive function. It was more frequent with the addition of whole brain to SRS, not just in the short term, but likely also in the long term. Adjuvant whole brain radiation therapy, as we expected from the preponderance of retrospective data, improved local brain control, but had no impact on overall survival. And there was clearly a worse quality of life observed with whole brain radiation therapy. And so I'll mention the reason why this is relevant to our preoperative SRS in a minute. But around that same time, there was already this de facto migration around whole brain radiation, away from whole brain radiation therapy. I think that this study really pushed a number of folks away from this. And again, I am not saying that there isn't a role for whole brain radiation therapy. What I'm saying is this it's accelerated the routine use of whole brain radiation therapy for oligometastases. And so, again, we push forward to where we are now. We've had some wonderful conversations about targeted therapies. I don't want to get into this issue right now. I think that there's tremendous uncertainty about whether we should be waiting on certain patients to see if they're trying to targeted therapies. I'm mostly going to be talking about patients where most observers even now would say they likely need surgery in the short term. And so we started getting interested because we had been looking at SRS in combination of whole brain. We then said, well, what is the optimal role of surgery in a multi-modality therapy situation? Most of the data we have relates to large symptomatic solitary lesions, and I won't belabor going over this in great detail because you folks are familiar with most of this information. However, here are the relevant studies for the most part. Of course, Paxill's New England Journal of Medicine paper many years ago, but subsequent trials also suggested that patients benefit from adding surgical therapy to radiation therapy for a variety of reasons. It seems to increase survival, decreases local recurrence, and decreases risk of neurologic death. If we ask the flip question, does radiation therapy add value to surgical resections for metastases? It seems that the best prospective analysis suggests that the answer to that's also yes. If you look at 1 to 2 year local recurrence rates, if you were just resecting these things, they can be fairly high. Adjuvant radiation therapy has been found to significantly reduce that risk. So as a result, in this environment. So let's just go back a couple of years, which is to say we had demonstrated a likely beneficial effect of surgery in select patients, and there has been this move away from whole brain therapy, whole brain radiation therapy, some of it cultural, some of it based on interpretations of the available data. A number of centers started employing single section stereotactic radiosurgery to boost the surgical resection site, to achieve local control and minimize the risk of cognitive side effects. And again, some of this isn't necessarily a linear thing. A lot of these things were going at different paces. Some folks adopted this very early on. The Solstice and Adler paper is already been mentioned. And I think it was very important for Dr. Agrawal to note that the de facto standard of care on the basis of this was that non-conformal or like less conformal therapy seemed to have better control. And so again, it became the de facto standard of care based on a retrospective analysis, which I find fascinating, but that's sometimes the best evidence that we have. And since then, a variety of studies have looked at postoperative SRS. Again, these numbers were mentioned before. Local recurrence rates tend to be relatively low. There are a couple of papers, that had higher rates. Mid-teens, low 20s seem to predominate. Radiation necrosis was a bit over the map. The Brennan studies seem to have a higher rate than others. I'll come back to that in a minute. What we thought was interesting fairly early on, that nobody seemed to be telling a story about this leptomeningeal disease. Whether it was symptomatic or not, how they were grading it, how they were even determining it was all over the map. But we kept an eye on that because we suspected there was more to that story, and in fact, there is. So again, a little bit of review, potential issues when you give postoperative SRS. Some studies have shown that some patients can't even get to their adjuvant SRS. So there was about a 20% dropout in the Memorial trial, a prospective phase 2 trial, because those patients, for whatever reason, never got to the postoperative radiation therapy. The potential risk of leptomeningeal disease, we're going to be talking about in detail. Defining the cavity, and I'll talk to that in just a second. And again, I'm not going to go over this in detail because Dr. Agrawal did, but if we imagine that these lesions are largely spherical, then it doesn't take too much to understand. Anybody who's tried to develop a outline around the lesion to the right knows how difficult it can be and how likely you are in some circumstances to include normal brain in the treatment volume. Whereas if you look at the left, it would be fairly easy to exclude a normal brain even in that large lesion. I don't want to say exclude, but minimize the exposure of a normal brain. So developing highly conformal plans is one significant benefit of this, but it is absolutely the case that we felt that preoperative treatment could reduce the intraoperative dissemination of viable tumor cells. I will say that our original ideas about this were largely right, but also probably wrong, because when we looked at our original dosing paradigms, they were reduced from the RTOG dosing standards because we felt at the end of the day, we're just going to be treating a rim of tumor cells in the resection cavity, and that's actually not the way we're looking at it now. Because we're removing these tumors, and because we are, in some circumstances, particularly with piecemeal resection, disseminating these tumor cells, at least in the local environment, the volume is relevant, not just the margin. But nonetheless, when we adopted this, and again, remember I said this is nonlinear. Even in 2005, we were thinking about it while we were doing our whole brain radiation therapy analyses, but we started experimenting, if you will, with this paradigm. And 1 to 3 patients were eligible. Most of the patients had a single lesion. We have an Novalis, we'll be getting a Gamma knife next year. And we talked about the 20% reduction from RTOG dosing standards. Most of the patients had surgery actually within 48 hours of SRS. This was the report that was referenced earlier. I believe this was the first a series that was actually published on this particular topic in the Radiation Oncology Red Journal in 2014. I'll go to the conclusions of this in just a second, but these were all relatively large tumors that were treated, and again with a slightly smaller prescription dose than you might think based on the size of the tumors. Since that time, there's been a variety of papers that have been published from our shop and others on this topic. Instead of just mentioning all our single our preoperative analysis that we published in Radiation Oncology Red Journal, I'll mention a subsequent analysis published the following year. There was actually a comparison between two institutions, ours that had been dedicated at that point to pre-op, and Emory that had been doing exclusively post-op. And this is the paper that was published again the following year in Neurosurgery 2015. It was really an eye-opening analysis. We looked at 180 consecutively treated patients at Emory and at Atrium Health, similar baseline characteristics. The local and distant recurrence was similar, but the incidence of LMD, radiation necrosis, and symptomatic radiation necrosis was significantly higher in the postoperative SRS group. And this is the bottom line slide here, folks. You can see in pre-op, exceedingly low levels of LMD and symptomatic radiation necrosis, far higher in post-op. And this is the first time we really felt that we were seeing significant signal. This was expanded in a variety of different contexts. We looked at a prolonged follow-up. Here's 2-year follow-up. You can see the LMD and radiation necrosis rates were remaining low. We actually did an interesting analysis looking at whole brain radiation therapy because whole brain had really been the standard for helping us prevent leptomeningeal disease. Interestingly, when we first started noting LMD, Mike Vogelbaum had mentioned to me, you know, it's interesting, we may have solved one problem and caused another, but by eliminating whole brain radiation therapy. He was specifically mentioning all these reports of LMD occurring, particularly in patients that were getting adjuvant SRS. In this particular paper, we were able to demonstrate that preoperative SRS appeared to be as effective as the quote-unquote gold standard for limiting leptomeningeal recurrence, so as good as whole brain radiation therapy. And these were our single institution analyses. Again, a number of these slides, folks, are for your benefit. These are just reference slides, and I'll provide some summaries because we've already talked about some of these things through Dr. Agrawal's analysis. We did a multi-institutional retrospective study of preoperative radiosurgery for brain metastases. Again, you know, looking at 1 and 2 years, excellent rates of local cavity recurrence and leptomeningeal development. We had submitted to CTAP about 3 years ago a concept for doing a pre versus post-operative SRS analysis. And after a long time, the proposal was denied. And it was largely denied around the idea that they ultimately came back and they said, we think this LMD is a radiographic phenomenon. We think it's, yes, nobody wants to see it, but you know, there's adequate salvage therapies, and you need to go back to the drawing board. And so we literally spent the next 2 to 3 years looking at this phenomenon in detail to see if it really was a problem. This is anecdotal. Here's a 50-year-old female with breast CA. This is her 10 months post-resection and adjuvant SRS. And she ended up dying of her leptomeningeal disease. We've seen numerous examples of this, and we became convinced that this was, in fact, a problem. We actually developed an LMD consortium. We started looking at a variety of things. We had a standardized a way of defining this. LMD is enhancing recurrence occurring greater or equal to 5 millimeters away from the surgical corridor. We actually have observed and now described and published a characterization of the way these LMD recurrences tend to manifest. There is nodular LMD, and it's self-explanatory. You see these nodular lesions, sometimes with a dural tail, and this more classical LMD that tends to be this fine, almost like sulcal disease, more consistent with typical dissemination of tumor cells, as we'll see in patients with widespread leptomeningeal disease. We published this patterns of a failure study. I won't get into that in detail. This is a very important slide, however, folks, because when we looked at our LMD patients from a variety of institutions, this is what we, by the way, that had surgery And then they had either preoperative SRS, and there were minority of patients in the study. Most of these patients had postoperative SRS. 88% of these patients who had LMD required salvage therapy for the LMD. The majority received a whole brain radiation therapy, which we knew were associated with those side effects that we talked about before. If you did not get treated and you had this, your survival was less than 1 month. So this is clearly a big deal. And interestingly, the majority of occurrences were nodular. In terms of differentiating these things, I will just mention, this could be a whole other lecture. Nodular LMD seems to have a slightly better survival than a classical, and patients are more likely to die a neurologic death if they have classical LMD versus nodular. Again, it's a story for another day. I think it's a fascinating observation. Our hypothesis is because these nodular diseases, frankly, easier to target with salvage therapies, that might be a reason why the patients have lower rates of neurologic death and they tend to survive longer. And we have now in this consortium been continuing to expand these analyses. And I'm going to move on here. So we were able to demonstrate to CTEP that radiographic LMD recurrence after surgery and SRS for brain metastases is clinically significant. Most LMD recurrences in the setting are nodular. And we mentioned that nodular LMD has a distinct biological profile. It is interesting, we did an economic analysis of this. And again, this is just a projection because of the rates of LMD and the number of patients being treated. If we projected that forward, our feeling was that if we were able to prevent or limit the LMD, there was a tens of $1 million per year range in potential savings just in terms of patients that are receiving more therapies. So in summary, and then I'll just mention the protocol before I finish, by simply altering the sequence of therapy, we could potentially improve the clinical outcomes in substantial numbers of patients undergoing surgical therapy for brain metastases. And those numbers are somewhere around 10% of the total number of individuals who develop a brain metastases. And so it is an incredibly high number. And when I gave this talk at the Academy a few years ago, I was coming in right after a talk for a subset of patients with GBM, and it was an incredibly elegant thing, amazingly complex and amazingly expensive. And if you really look at this, there is no negative financial impact to doing this. Again, this is simply changing the order of what we do to achieve what we think could be a very large return on investment. I'm going to go past these slides for a second, folks. I do want to mention that we did change our treatment paradigms recently. We have gone to the RTOG standards for a variety of reasons, and we can discuss that at some other point if you'd like. So finally getting to our new NRG trial, we have finally been approved by CTEP to move ahead. In fact, we found last week that the first patient has been enrolled. We are anticipating 236 patients being enrolled in this. Our primary endpoints is a composite endpoint looking at the cavity and the second endpoints tend to be all these other things: PROs, neurocognitive functioning, overall survival, whole brain radiation therapy. But we're obviously very interested in the development of leptomeningeal disease. We are stratifying on the basis of these various factors. Lesion number, we had mentioned posterior fossa versus supratentorial. Breast cancer histology, because our anecdotal observation is that if you get LMD from breast cancer, that is a really, really bad actor. Patients do horribly with breast cancer for reasons that we just do not understand yet. This randomization protocol, and the study was activated in August, but again, because of individuals having to get this through the IRB, we're just now accruing patients. A variety of organizations participating through the cooperative group consortiums. And I mentioned biospecimens earlier. We are going to be looking at CSF obtained at the time of surgery, serum, and then of course the blocks will be analyzed from the tumors. I know that we're at time. I'm going to mention just two more things if I could. We are now using fractionated SRS for preoperative treatment of what we call high-risk lesions. Every single one of these things would likely have to be resected via a piecemeal approach, or they're so necrotic they would fall apart. And in our world, we feel that they would place these patients at risk for LMD. I talk about the myth of en bloc resection when we have tumors in critically ineloquent areas where we want to do very small exposures. We necessarily have to work sometimes through 3 millimeter corridors or sulci, various things where doing an en bloc resection simply is not technically feasible, nor is it safe. It has been suggested to us if we just resected all these things en bloc, this would all be unnecessary. I think that that's a ridiculous consideration. I have no other way to put it. We take out big tumors, symptomatic tumors. If somebody had a small right frontal met that might be amenable to en bloc resection, is probably also amenable to definitive SRS. I'm going to conclude with this slide. I wish I could show you all the other ones, but I want to be respectful of your time. We have found fairly definitively that in this particular circumstance, which is to say neoadjuvant SRS, that radiation is tremendously immunomodulatory. We are seeing substantial expansions of cytotoxic T cell populations within these tumors. The clinical implications of that are not well understood. But we do believe that if we believe in things like abscopal effects, et cetera, there could be at least some regional benefit to this. And we are looking at some preliminary protocols where we might augment this effect with, for example, PD-L1 inhibition shortly after giving the neoadjuvant SRS and before surgical resection. And again, if anybody want to talk about that in the chat or afterwards, just feel free to contact me. But I'm going to conclude there, folks. Again, I really appreciate the ability to participate today. I've learned a lot. I'm super excited by some of these potential areas of collaboration, the liquid biopsies to me, and particularly if we're looking even in the course of surgery, you can imagine doing an analysis, as you open up, looking at CSF, getting serum, and then doing the same thing immediately after resection. We might find some really interesting biologic correlates to our clinical observations. So I'll wrap it up there. Thanks again.
Oh my gosh, Dr. Asher, thank you so much. That was just a fantastic talk. Really beautiful demonstration of the need for kind of a paradigm shift for how we approach these Mets. And, something as simple as a sequence change could have such a profound impact. I do have additional questions, but we'll wait until the panel discussion at the end, if that's okay with you. And our last speaker today, but certainly not least, super happy to introduce my very good friend and colleague, Dr. Zabi Wardak. Zabi is a radiation oncologist at UT Southwestern, where he's the chief of central nervous system radiation oncology and the medical director of their Gamma Knife program, where he and I have had an opportunity to collaborate quite a bit. He's heavily published in the use of SRS and the treatment of both benign and malignant disease, and the utilization of artificial intelligence tools actually for brain metastases detection and treatment. So I've always known Zabi to be at the leading edge of innovation, and he's going to share as kind of an adjunct talk to what we heard this morning from Dr. Weinberg about his experience with GammaTile and the management of intracranial malignancy. So Zabi, thank you so much for joining us. I am really looking forward to your talk.
Yeah, no worries. Thank you, Dr. Bovey. Can you guys hear me okay?
We sure can.
Okay, perfect. All right. Yeah, so this is going to be the radiation oncologist perspective then on GammaTile. And certainly, as Dr. Weinberg said, it's not often that we get to scrub in, so that is why I have titled it as such. So disclosures, I have some funding for the AI research, Gamma Knife training program director, but have no affiliation with the GT Medical or GammaTile company. If anything, I usually give them a hard time. Here in our facility, we have plenty of technology. So when it comes to a patient's candidacy for intracranial radiotherapy, we have plenty of options. We have MR-Linacs, We have multiple gamma knives. We have cyber knives. So we're always looking to utilize whatever is best for each individual patient themselves. So these are my colleagues here on the CNS team. All of us are utilizing the gamma tile, and these are our neurosurgical colleagues. We have many of them, and we love working with them. As Dr. Asher just mentioned, the collaboration between us and neurosurgeons is essential. We've learned a lot from them, and really we approach cranial radiotherapy ideally from a surgical perspective. These are our neuro-oncologists who also are essential for a gamma tile program, not only for METs, but also for gliomas as they would evaluate patients for candidacy. So Dr. Weinberg has discussed the physical features of the gamma tile itself, but it's a 2x2 collagen matrix with 4 cesium-131 seeds that are embedded within the collagen matrix. They're spaced 1 centimeter apart. As he mentioned, there's an offset. So the idea here is that there's 3 millimeters between the cavity surface and then the seed. And the idea here is to provide a bit of a spacer so you're not having the seed directly onto the surface itself. So there's a short half-life for these seeds, just under 10 days, has a low energy photon, so its dose is delivered very locally, and the dose is given 90% within 1 month. So it's great in that it's very potent and given very quickly. There's really negligible time added to the OR. There's standard postoperative care, and the patients aren't kept in the hospital any longer than they need to. So our experience, we started in April of 2021. I think the company as a whole, they really started to get FDA approval around the time of COVID. So I think that slowed things down. And now I would say it's almost an avalanche. Most facilities are going to start, if not already, offering this for their patients. So we've treated now 14, and I would say about half of them have been brain mets, a lot of recurrent gliomas, and 1 atypical meningioma. So administratively, when we were starting our program, as Dr. Weinberg mentioned, you could see here on the right, these tiles, they are expensive. So we had to go to the hospital. We had to look at what's our estimated number of patients, looking at the payer mix, and then seeing, whether or not this is something that's feasible. And certainly when you go through it, the hospital should be able to see that this is not only clinically, it's a good program, but also it makes sense from them from a business perspective. And then when it comes to the clinical logistics, of course, there's multidisciplinary discussion amongst all of our colleagues. And really, the neurosurgeons and us, we work together regularly when we're doing SRS. So our coordination is always essential in getting the timing right. So who do we choose when it comes to brain mets for gamma tile selection? Ideally, of course, they're going to have the capability of undergoing a surgical resection. They would have a decent performance status. It's great if you can find that patient with a solitary brain met and has absence of systemic disease. More often than not, that's not the case, and they have systemic disease. But really, we're looking at patients, they're not at the end of the line. They have treatment options available. And also with discussion with their medical oncologist, they have the capability of taking a break from their systemic therapy so they could undergo surgical resection. So just some background on cesium-131 itself. So there's a good bit of experience, as Dr. Weinberg had shown, in New York, where they were using not the collagen matrix, but these were stranded seeds. So individual seeds that they were placing right within the resection cavity. And what they found with their experience was that within 5 millimeters of the seeds, there was no recurrence. And in this study, they did find 1 recurrence just beyond that. And that really just highlights its gradient and its capability of controlling things locally. But you do get a steep fall off in dose beyond that. And then most importantly as well, there was no incidence of necrosis. So there is other seeds that can be used for intracranial brachytherapy. I-125 comes to mind, but there are high rates of necrosis. So the gamma tile is nice in that, 1, you're not placing loose or stranded seeds directly onto the parenchyma itself. You have that spacer. So the incidence of necrosis will hopefully be very low for your patients if you choose to utilize this. So that same group in New York, then they were doing a matched pair analysis of cesium-131 versus SRS. We've had a lot of discussion here between different ways of delivering radiotherapy. And here they looked at patients who underwent post-op SRS. Here this was LINAC-based. They were giving anywhere from 1 to 5 fractions in the post-operative setting. And they matched it to a cohort of their patients who underwent cesium-131 brachytherapy. What you can see here on the right is that the local recurrence with the brachytherapy, they had 3 patients versus 17 with the adjuvant external beam radiotherapy. So definitely an improvement there in local control, albeit not prospectively. So then they also looked at, for larger Mets, here we're going to be looking at 2 centimeters or larger. And when they focused in on that, again, looking at a 12-month control rate on the right of 100%, that really is excellent, especially as we always have this issue as Mets get larger, then control rates start to decrease. It was interesting to see that there were some complications related to their implants. There were 3 wound infections, and then also there was 1 patient with a seed migration that they found in the spinal canal when the patient was undergoing routine CT, chest, abdomen, and pelvis for surveillance. Thankfully, this was beyond the seed having decayed entirely, but if you're placing loose seeds, that is also a potential issue. So the tiles themselves, this is another added benefit in that they're vicral sutures that are embedded within that collagen matrix. So there's not a lot of data out there as far as gamma tile when it comes to brain mets. You know, this is something that's really just taking off. Initially, the company was localized out in Arizona, and they were doing in a single institution. They had a basket study of about 100 patients that they enrolled and then ultimately got FDA approval from. They went and they looked through that 100-patient cohort, and then they found 16 patients who had brain mets within that cohort, and they looked at their control rates. So for mets that were less than 2.5 centimeters in size, they had 100% control rate, and that 2.5 centimeters or larger, that control rate dropped as we commonly see, albeit still decent at 75%. And when they looked at incidence of necrosis, it was a small patient cohort, but there was 1 patient who had necrosis, and then that led to a 12% rate. So that is something that has the potential of happening, and you always want to counsel your patients about that if you choose to go with it. So what are the technical capabilities and features of how you would start your program? So when it comes to our planning process, as mentioned, we get ideally no later than 1 week prior to the prospective surgical date, brain lab, SRS protocol, MRI, and we do contouring and we do the tile estimation in conjunction with our neurosurgical colleagues. Our physicists, they're the ones who order the tiles. We ideally want them to arrive 2 days in advance. And really that's just to make sure that there's no shipping issue and we have a 1-day buffer. And the physicist will then verify that there's a loose seed that comes, and I'll show you the package contents. And that loose seed, they verify that the dose delivery from that is what the tiles are representing. And then on the day of, then the radiation safety officer and the physicist, they come to the OR with us with the tiles. So this is a nice paper that came from Minnesota about a year ago, where they really laid out their program development. So if this is something that you're looking to start within your facility, this is an excellent guideline that we use as well in helping to start our program itself. So with the pre-planning and the tile estimation, now what the Gamma Tile company does is they provide you with MIM. And what you could see here, then this is your workflow. So there's a workflow here in the top right. After you import in your treatment planning, you could think of MR. You can run a Gamma Tile pre-op workflow. What that then is going to have you do is then start your contouring just as you would in any other software. And here you could see it's gonna automatically label here your structures. Your pre-op tumor is going to be contoured. Here you can see in the bottom right, this is the workflow, and it has a step-by-step guide in how you would work through this. And what we commonly do, and certainly you discuss this with your neurosurgical colleagues, you know, how much is that brain going to potentially contract after that metastasis is removed? As a general rule, we commonly use 3 millimeters. Of course, that's not always the case, but we're looking at this as being the contraction volume itself. And then the next step is then we contour out an exclusion volume. And then I know this was a question with regards to whether or not we place any tiles along the dural edge. So along the craniotomy site and then the anticipated route that the neurosurgeon is going to take, then we contour that out as an exclusion because we would not be planning on placing any tiles there. And this is all just standard workflow, which is here established within MIM. And what's going to happen next is then the software is going to spit out a surface area here in the bottom right, which is going to be your adjusted tumor, which is your contracted volume, minus your exclusion volume that you have. And then what you're going to do is you're going to look at that, and then you're going to estimate the number of tiles. Each tile covers 4. So here you would look at it and you would say 1. There is a minimum order of 3. So you would have to at least order 3. This patient ended up using 2. So you will find that there is some subtleties such as that. And again, we really aim for a week prior to surgery to submit the order, although they say you can order it as early as 4 days in advance. The company's been very helpful. We've had tiles delivered over the weekend. We've had tiles delivered the morning of. Certainly, it's not a pleasant experience for the physicist, but it is something that can be done. Here's a couple of other examples here. So a couple of other patients with brain mets. Here you can see in the top, you can see the contouring of the target. You can see the contouring of the contracted volume and then the exclusion. And then here you could see 37.7 centimeters squared. So here you would look at it and then just divide by 4 and then get your tile estimation. As Dr. Weinberg had mentioned, there is an issue. You don't want to have more tiles than what you actually end up needing. They are very expensive. So what we found is that division by 4 actually can overestimate the number of tiles for us. So we usually will look at least 1 to 2 tiles less than what that quantity actually is. So this is the packaging, and this is exactly what comes via FedEx. And here you could see this is a shielded tray in the bottom. This is a loose seed that the physicist is going to check to ensure that the source strength here is what the documentation and the actual tiles themselves are going to have. So these are our documents and what the physicist is going to go through. There's a checklist here on the left. They're going to go through radiation safety, check the calibration of the seeds, make sure that the exact number are there, identify and confirm the patient's name and date of birth. And then there's going to be a written directive that us as the radiation oncologist prior to surgery, this is our prescription. We're going to sign this at the completion. Let's say we ordered 8 tiles and we only used 7, then we're going to write that down here in the written directive. And then the physicist is then going to survey the room. They're going to look to make sure there's no loose seeds on the ground, as well as perform a survey after the skull has been closed. And what is our role? This is certainly, like we mentioned, this is a rare opportunity for us to come to the OR. And really for us as a radiation oncologist, there's not much in there that we have to do. So what we do is then we work with the surgical scrub techs and we set up a Mayo stand. There's going to be a sterile shielded tray that we're going to set up on the counter. Then the physicist is going to bring the tiles. They're going to be sterile here within this package. We're going to take it out. As Dr. Weinberg had mentioned, then what we do is then we place a mark on the back side of the tile itself so you can visualize it. So this here on the right is what we don't usually do. We always want to have that mark so when we are looking into the cavity itself, we can see that the bumpy side or that 3 millimeter offset is facing the patient's brain. And then afterwards, again, we're going to do this on the left, the completion procedure and quality management checklist. These are the documents that we send the patient home with, and we place this in the chart. So what the physicist does is that they're going to look at a mathematical calculation of the decay of the source strength of the tiles. And then once they look at that, once they get below this 1 millirem per hour, then they're going to say that's how many days ideally you should stay away from pregnant partners, children, etc. So after the patient has undergone resection, we commonly get a brain lab CT post-operative day 1. We also get a post-op MR, and then we register this in the MIM. The physicist is then going to locate the seeds on the CT, and then we're going to generate target volumes as we commonly do in radiation oncology. So we do the seeds plus 3 millimeters is our GTV, and really just lining the cavity itself. And then we put 5 millimeters on top of that as our planning target volume. So this is from the clinical trial that Dr. Weinberg is running, and this is looking at the dose parameters. So we're looking at prescribing 60 gray at 5 millimeters depth. So these are some critical structure constraints. So you certainly would want to look at your patient candidacy for the procedure based on proximity to the optic pathway and brainstem. So this is Dr. Weinberg's study, and I won't really go through this, but what this is doing is randomizing patients to either post-operative gamma tile versus adjuvant SRS versus or FSRT. So just a couple of cases, certainly we didn't have the cleanest of cases for the metastases patients, as all of ours have been recurrences. This is a patient with metastatic colorectal cancer, and he came in, he underwent resection. He came in and we saw him prior to the program, and then he underwent adjuvant SRS. We thought we were being clever here, so we had an SIB when we treated the patient on the Gamma knife, treated 30 gray and 5 fractions to the gross residual, and then we did 5 times 5 along that dural edge. Within a short time period, the patient underwent repeat imaging and suffered a significant recurrence. At that time point, he underwent resection. Here you could see the tiles that were placed. And locally, things were controlled. Here you could see, this is the dosimetry. We always like to get our post-op MRI registered with the CT so we can look to make sure that that 60 gray isodose line is actually encompassing what we would want to see within the cavity itself. So locally, he was controlled. Unfortunately, as is uncommonly seen, is nodular leptomeningeal recurrence. And we salvaged this with SRS, but the patient himself, he hasn't been doing well. So it's not always the greatest of stories, but locally itself, if that was his only site of disease, it worked exceptionally well. This is a bit of a happier story. This is a patient with metastatic melanoma, underwent surgery at an outside facility, came to see me. This was his postoperative scan. He underwent SRS. And as we've mentioned here in several talks, our dosing to the resection cavity was based off of these seminal studies that were performed. And we gave this patient 17 gray to the cavity. Problem is that when you have METs that are larger than 2.5 centimeters, if they undergo adjuvant SRS, your local control rate, here you can see in the green and red, drops down precipitously. So this patient had a recurrence within 6 months, and he wasn't so keen on undergoing the tiles. He just wanted to undergo surgery itself, as could be expected. Then 3 months after his second resection, he had, again, a local recurrence. So we talked to the patient about a third surgery. He was against it. He wanted to undergo another course of Gamma knife. So we brought the patient in just a few weeks later for a reirradiation treatment. As you could see, he had a pretty significant and brisk local recurrence and progression. So when we saw the patient, we said, hey, we could treat this. It didn't work the first time. It's unlikely it's going to work the second time. You have no systemic disease. Ideally, you would want to undergo another resection in the tiles itself. He was still wavering, and he decided he wanted to undergo the surgery a little bit later than what we would have wanted. So what we did is we actually bridged him until his third resection. We gave a moderate dose. We gave 18 gray and 3 fractions just to try to keep that tumor at bay until he did ultimately undergo surgery about a month and a half later. At this time point, this was his third resection. He had the tiles placed. Here you can see the CT and the dosimetry on the MR in the bottom right. 6 months later, he's been doing well without any evidence of recurrence, no systemic disease, so hopefully he'll do well. So what have we learned? Just some things from our time in the OR. So it's always good to have at least an additional sterilized shield available if for whatever reason your radiation oncologist is clumsy and drops it on the floor. Certainly you want to work with the neurosurgeons regarding the time frame as far as when they're able to get the patient in for surgery, as well as the time during the day so you can coordinate with radiation safety and your physicist. We've also had to contact our pathologist prior to the case. So it's very often tricky if you're treating a patient in the reirradiation setting. You have that question of malignancy versus necrosis. And in our first patient that we treated, our pathologist came back and he says a few hours after the case is done that he feels this is necrosis. Whereas in the frozen section, he told us that this was a recurrent glioma. This was a recurrent GBM. So certainly there was a lot of anxiety. This was on a Friday. We're wondering whether or not we got to go back in and take the tiles out. So now we just let them know and say, okay, we really need to know. You need to be confident and confirm that there truly is malignancy before the tiles are placed. So as Dr. Weinberg showed, we cut the tiles if needed for getting around corners and for placement. And there is a discussion of flipping the tiles, so you know that there is that offset of 3 millimeters. If you flip it, and you have some gross residual disease, the idea there would be that you could get dosed to a deeper section. Problem we found with that is when we did it early on, we did have necrosis, so we no longer do this, and we just stick with the bumpy side to the brain. And just in summary, then I would say, there's a lot of options as have been discussed here during this seminar. For patients with brain mets, the GammaTile, I think, is just a natural extension of that. If you don't have this, patients eventually are going to expect this as being a standard option that's available to them. Thank you.
Thank you so much, Zabi. That was just an amazing talk, and I feel like a very nice adjunct to what we'd heard this morning from Dr. Weinberg. That wraps up our scheduled talks for this session. We'd like to open up the floor for questions. I do have one for Dr. Asher, actually, just with regard to BN-012. At our own institution, we've grown very comfortable and have really enjoyed the outcomes of post-operative stereotactic radiosurgery to the cavity delivered in a fractionated way. And I know you talked about that and touched on that briefly, but I had just pulled up the protocol and had recognized that there's not a fractionation option actually for the in the post-op setting. How do you feel like that's going to be reconciled with the analysis of BN-012, especially with the recently closed Alliance trial and the precursor to that showing perhaps benefit of fractionated treatment being superior to single fraction in the post-op setting?
This actually came up yesterday. Depending on the Alliance trial findings, we may modify the protocol to allow for fractionation in the post-operative setting. So University of Michigan posed that question. We are presently not in a position to do that just because those results are not available. But everybody knew that was an issue going in. I will say, from my standpoint, it doesn't change anything as it relates to LMD because, it's a local cavity control thing. And as I mentioned before, on the basis of the Stanford analysis not long ago, we changed our dosing parameters. So we no longer have the 20% dose reduction. We do the standard RTOG doses to the cavity. And of course, I did mention we're doing fractionated therapy, for the larger lesions. But I think it's an extremely valid point, and sites should have the opportunity to do that. I don't think it's going to change the end result, though. We may find that maybe there's better local control in the patients that have fractionated therapy. It could be marginally better, but again, if we don't see a change in the LMD numbers, then our major hypothesis, is going to be proven to be incorrect. And in that setting, you could imagine a situation where people could choose either form of therapy. But retrospective data suggests to me that won't be the case.
Very good. Thank you.
I have a question for both Dr. Weinberg and Dr. Ward. In terms of previously treated SRS, most of the time pathology is a mixed bag of necrosis and malignant cells. So is that something you analyze pre-op before putting these GammaTiles? Or is there a percentage that would make you want to put the GammaTile versus not put the GammaTile?
You want to go first?
Sure. It's a great question, and it's always an issue. That's why for us, we always want at least that confirmation of malignancy that's going to be in there. We never look and try to quantify within that frozen section how much of this truly is necrotic versus metastasis or not. If we get that confirmation, that's our go ahead. And usually, we do our due diligence prior, and we have a good sense that the majority of this truly is recurrent tumor.
Yeah, so I think when you go into, once you make the decision to go to surgery, if you're considering using the tiles, you really have to have a high suspicion that it's tumor, because otherwise you're wasting tiles and you're incurring a big expense that's going to get lost. So, I mean, in our practice for the recurrent Mets, They have to have solid enhancing disease. They have to have progression over a series of scans. We have an MRI set of sequences that our radiologists have put together called ABTI, Advanced Brain Tumor Imaging. We do a combination of spectroscopy, diffusion, perfusion, all these other studies where you have as great a sense of confidence that there's recurrent disease before you go to the operating room. And I think with that confidence, we've been able to minimize the wasting of tiles. I mean, fortunately enough, about 2 weeks ago, I had somebody with a recurrent MET and we couldn't figure it out, and we didn't have tiles, and it was all radiation necrosis. And then the radiation oncologist reminded me, no meat, no treat. That was their statement. So it does remind me that every time I get a little cocky and say, well, of course this is tumor, what are you talking about? That sometimes when they pester me to get tissue to verify the diagnosis, that they're actually right.
Dr. Asher, you had your hand raised.
Yeah, I'm going to be just maybe a little provocative here because both Jeff and Zavi had some really great analyses, but I'll just go ahead and say it. You know, so the company, obviously, with our volumes, approached us a while ago. We still have PTSD from gliosite, and I noticed a similar phenomenon, guys, and I think that it has to be said. The uptake was incredible. Now let's just also go back for those of us who kind of remember the days when Gliadel was first coming out. It never achieved escape velocity. And again, I'm going to be a little cynical here, and part of it has to do with the fact that surgeon never got paid for it. Okay, there's just no extra payment, and if you aren't absolutely convinced that that it is efficacious, you're not going to use it. Flash forward to gliosite, even at a time where we actually published a tongue-in-cheek editorial. Bob Fraser was the lead author, and he called it "Unsafe at Any Speed." We literally could not go to a low enough dose where we weren't achieving radiation necrosis with gliosite, and we abandoned it. But the uptake was unbelievable. And the fact is that the company had to be careful what they were telling everybody to put in, the unlisted code, which generally would be about 30 work RVU equivalent, and then probably put on a stereotactic code on top of that. I'm just saying that I'm hopeful that thoughtful people like you are guiding this in as scientific a way as possible, because a lot of the uptake previously had to do with the fact that it was lucrative for hospitals, it was lucrative for clinicians, and I'm not aware that we ever really demonstrated substantial benefit from that. And the only other thing I'll mention is that on the flip side of that, we did tell the company we'd be willing to participate in investigative capacity. We know that we need better options for patients with recurrent disease in particular. We know that we need, we actually think that we're very excited, and maybe it's your trial, Jeff. I know that there's an upfront GBM study either ongoing or being contemplated. That makes sense to me because we're already kind of doing this cavity boost. But some of these things for which we already have pretty good therapies, I just happen to know some folks in some centers who all of a sudden wholesale have just switched over to using this as a routine. And whenever I see that, I become concerned that again, there are forces other than good scientific information that are propelling us into those realms. I would love for everybody to be as thoughtful as you guys are in looking at this in a very evidence-based way. So I'll just throw that out there. But and by the way, I believe it's the same isotope, right? As gliosite. Is that correct? Was it?
I believe that was I-125.
It's not cesium.
Yeah, that one was, I believe, I-125. So
I-125. Okay, fair enough.
yeah.
Okay. Anyway, just any thoughts about that, guys? I mean, it was just a phenomenon. Then you have a company, frankly, I'm sure that they've got a lot of, they have put a ton into research. I'm just stunned. They must have an amazing amount of financial backing behind them. And so they need to be applauded for sponsoring studies such as what you're doing. But I'm also getting the sense that they are being very aggressive about pushing this for indications for which I think we really just don't have a lot of great evidence.
Yeah, I can comment first. I appreciate your comment, right? This is the sort of the bane of the existence of a neurosurgeon, somebody walking into your office and saying, hey, look what I got. I got this widget, I got this therapeutic, and it seems really safe. Go ahead and do it, right? I mean, GBM, we've applied logic to curing GBM for 50 years, and we still can't budge the needle beyond the 14 to 16 months in really appropriately selected patients. We had a bit of an issue with the company to begin with because they were trying to force us to use it even outside of the clinical trial, and we pushed back a little bit. We really like the idea of bringing it in with the clinical trial. Our group was a little reluctant to do it for the GBM trial, and they are still trying to push us to do it, mostly because of the way it, and I don't remember the specifics, but the way it meshed with the STU protocol and the radiation that's given, and whether or not it's adequate and similar, and whether the dosing is the same. So we are not yet participating in that trial, and we've given them comments back from our radiation group. We like the trial, obviously, that we're running, and I think when we have some of these METs where we really have failed radiosurgery, resection, repeat radiosurgery, lit, and for me it seems to be the GI cancers that are just so sticky and resistant to everything. It's cleared safety protocol enough that the FDA has approved it for this indication, so we're using it. It's not for every patient, but for the recurrent patient after we've thrown a lot at them, we're using it. Obviously off protocol, but for the accepted indication.
It's good to know. Thank you.
Yeah, and our experience has been similar. You know, they came to us and we all had our skepticism, and primarily that's why for us we've used it for recurrent brain mets after they failed all of our prior standard of care therapies. But we're encouraged by what we've seen for those patients. You know, when they failed, at least up to this time point, we'll see as time goes on, see how the necrosis risk truly plays out as we reach that 1 year time point. But for these cases that are not controlled and they have recurrence with SRS within 3 to 6 months to now get past that time point after the patient has been previously irradiated multiple times, had multiple surgeries, I think we've been encouraged, at least for the metastasis patient. Certainly we've done it more for gliomas, and there I would say, you know, then it's a little bit more questionable how efficacious it is.
I admit that the data, and it might have been from Barrow, regarding recurrent Mets was reasonably compelling.
Wonderful discussion. We do have one question on the chat from Dr. Puckett. This is directed to you, Dr. Yip. Are there any takeaways that you've been able to institute in the clinic as a result of your work, or is a lot of this still largely investigational?
I think because I work in the Canadian landscape, so it's very different from the States in terms of funding and reimbursement. So, but I think what I mentioned about reflex testing, agnostic of stage, I think is as important, and that I think we're moving toward that. And I think at the end, we're just going to be testing the same patient, but earlier, in which we actually have much better tissue in terms of quality and amount. And if the patient becomes a higher stage, they will be funded for testing and the drug as well. So why don't we test at an earlier stage? So I think a lot of these are standard of care in terms of multi-gene panel and all that. And I think the only thing which are still somewhat preclinical is a wholesale liquid biopsy testing scheme for CSF and blood. We do have funded indication for certain types, for example, prostate cancer, in which we can't get sufficient tissue, and then we rely on liquid for identifying BRCA1 and 2 so that we can put the patient on olaparib. But I feel that we really need to consider liquid as a viable option for more indications. particularly from CSF as well. I mean, that would be extremely useful for like even pediatric patients with K27M mutated DMG, and that was a great way to monitor disease. So I feel that we really need to move on there. But I think it's a combination of a lot of the what I talked about is already standard of care, but we really need to sort of expand it to more patients, and that's the only restriction is the funded like the budgetary landscape. But then liquid biopsy, I think we definitely need to sort of move that to more clinical use.
I couldn't agree more with you. I think one of the limitations that we have in the States is just availability of repeat testing on patients. You know, I think we do a really nice job in evaluating these folks up front with foundation testing in order to help drive, or many different types of testing, whether it's foundation or Tempus or whatever you're using in order to help drive that initial course of therapy. But, you know, what I gathered from your talk, and especially with all this discussion with regard to resection of all these metastases, I feel like we should be testing every single time the patient has a tumor, a portion of their tumor removed, in order to see if things have changed to the point where you need to redirect your systemic options or your even focused radiation options. But I agree with you. We are kind of stuck in a situation where it would be cost prohibitive to do that.
Yeah, I totally agree. For Canadian patient, foundation is a self-pay option. It's about $7,000 American. So that's quite prohibitive.
Yeah.
Like for the panel test that I sort of shown in the Oncoprint, we managed to get the cost, at least for us, down to $800 $800 Canadian. That would be DNA, RNA, but obviously you get what you pay for. So $800 for a 52 gene panel, certainly not comparable to a foundation test in which you get a couple hundred genes, you get total mutation burden, and you get HRD score, which actually could be quite useful. So it's really about sort of moving the technology forward so that we can actually do it in an economical manner, but also in a way that would accommodate low input material. One of the things that we found has been consistently a problem is often we get like for lung EBUS cytology specimen, which are maybe have 20 cells, 30 cells, and we need to provide a full suite of molecular information from that small amount of material. And I think we're actually moving toward that. A lot of tests are getting a lot better now so that we can actually use very limited material. The next big move is to make it cost effective enough so that payer will be agreeable so that we can move on to not more expansive testing, but also repeat testing on patients.
Very good.
Now I have one last question for Dr. Weinberg, just to follow up with what Dr. Asher was saying. Like when we placed Gliadel, watertight dural closure was the key to not get post-op complication in terms of infection, wound breakdown. But for GammaTile, you said you do resect the dura if it's the dural infiltrating met, and I assume you're putting some kind of dural substitute. So is that not that big of a deal when it comes to GammaTile versus what we saw with Gliadel?
Yeah, so good question. So for the one case that I showed with the dural involvement, there was still disease where we couldn't see extending beyond the craniotomy flap and slip the tile under the dura. But you absolutely put a patch in. There is the data from everything that's been published so far, either with the strands or with the tile, has been no increase in infection, CSF leak, dural breakdown beyond that, which is expected for the previous historical papers that describe complication rate for reduced surgery. So there does not appear to be increased complications for CSF leak, wound infection, brain infection, similar to the I'm sorry, you just about the I'm blanking on the we never used it for the BCNU wafers.
Yeah,
we never used them. And we did one, and Tony, we did one case with the balloon on a trial, and that was a nightmare, and we never did another one.
It was a scary experience for a lot of folks. To that point, we're trying to do some there was some suggestion based on some work that Dr. Brem did at Hopkins that there is a potential synergy between BCNU and temozolomide. And so a while ago, we actually did, first of all, recurrent in an upfront trial, looking at resection BCNU wafers. We gave temozolomide that would have been like a standard monthly dose, a fairly high dose starting postoperative day 3. And then the patient would go into the standard Stoop protocol. Interestingly, it was before we were routinely looking at IDH1 and a variety of other things, and the tail was ridiculous. I mean, like 8 years out, we still have about 6 or 7 patients who are alive, believe it or not. But where I'm going with this is that we were stunned to see that none of the roughly 60 patients we treated had any wound issues at all. Now, that was in contrast to some patients that we've been doing some similar protocols in the recurrent setting. And I understand comparing MET patients to GBM patients is a little different, but particularly because some of these folks had fairly very high doses of local radiation therapy over a broader area. But it seems that people in an upfront setting, from a wound healing standpoint, will tolerate fairly significant amounts of therapy before they get into trouble with wound issues. I've always found that fascinating.
Well, this was just excellent, everyone. Thank you for the folks online that have stuck around. I've been thoroughly impressed with the talks, and then just love the post-talk discussion. This has been wonderful. So thank you to our presenters. Thank you to our hosts. Thank you, Dr. Day. Yeah, this has been just great. And we are happy to give you back the remainder of your Saturday afternoon, but thank you for spending the time with us on a Saturday morning. This was wonderful.
Yeah,
Thanks,
I
guys.
just say the same. Thanks, everyone. And also thanks a lot to Brittany and Caleb for making this. I mean, they really made this happen. So really a big thanks to Brittany and Caleb for helping with everything. And of course, to all the speakers for spending their Saturday morning with us.